Trial.
Hello. Yes, your microphone is working.
Trial. Trial.
Mr. Nozim John, your microphone is saying trial, and we
Trial.
cannot hear you. You could be using a third-party program.
Yeah, can you hear me now?
Yes, yes,
Yeah, okay. I switched my microphone. Yeah, okay.
yes, we can hear you very well.
Minute. Can you see my slides?
We can see the share screen, but not your slides.
Okay, 1 minute. Let me try again. Yeah, can you see my slides?
Yes, we can.
Yeah. Okay. All right. 1 minute. Yeah, I think now it's okay. Yeah. Well, hello everyone. This is Nazim John Tigunov. I am Master of Dental Science from University of Malaya, and I've been working in University of Hong Kong in HKU. And today I'll be presenting my research entitled Fabrication of Novel Nano-Sized Glass Ionomer Cement Formulation with Enhanced Bioactivity Properties. Well, here's the outline of my presentation. Well, let's start with introduction. So as we know that conventional glass ionomer cements are acid-based cements with widespread usage. It presents a better preventive effect on caries than other restorations on primary and permanent dentitions. It has some advantages and disadvantages as well. Advantages like chemical bond to enamel and dentine, fluoride ion release and its accumulation, reduced microleakage on dentine, biocompatibility, anticarcinogenic action, and cost efficiency. However, it presents some disadvantages, which are high wear rate, poor mechanical strength, less aesthetic, initial setting time to water loss and uptake. Well, if we will be talking about the chemical composition of our conventional GICs, it consists of about 80% of silicon oxide and aluminum oxide and 20% of additional chemical elements, which might be fluoride-containing agent, sodium, and heavy metals like lanthanum and other heavy metals. Well, if we'll be talking generally about its particle size, basically glass ionomer cements are not divided by its particle size. However, the particle size of our material can be varied from 5 up to 20 micrometers. So here on our right hand on the table, we can see the different particle size of the different commercially available conventional glass ionomer cements. And tetracalcium phosphate, this is one of the type of calcium phosphate which calcium and phosphate ratio greater than hydroxyapatite, and which value is 2. Studies have shown that TTCP can promote osteogenesis, exhibit dentin breach, and can be used for dentin hypersensitivity, has high biocompatibility as a pulp capping agent, stable in bacterial medium, and can be used for root canal perforation. Additionally, it increases remineralization properties when it's used in chewing gums or in toothpaste. Hydroxyapatite or HAP, this is also one of the type of calcium phosphate, which calcium and phosphate ratio is 1 to 1.67. Well, studies have shown that HAP holds significance in medical and dental domains such as osteoporosis treatment, alveolar bone repair, and prevention of dental caries. In toothpastes, it is also shown a good properties when it was used as a repairing agent. Additionally, it enhances bioactivity properties of the material used in restorative dentistry, and some studies have shown that HAP increases mechanical strength of our material. Well, nanotechnology in dentistry are so based on the ISO standard. Nanotechnologies are the particles, the materials which dimension of the particle is from 1 up to 100 nanometers. So limitations of the nanotechnologies are follows, which are biological limitation, chemical, mechanical, social limitation, ethical, or there might be economical limitations as well. Well, statement of the problem. Well, as we know that in conventional glass ionomer cements, the bonding between the conventional GIC and tooth is weak. Why it is weak? Because a stronger chemical bond could be achieved by fabricating GIC with true bioactive properties. For example, formation of hepatite interlayer by enhancing fluoride, calcium, or phosphate ion release. For conventional GIC, it is considered difficult to form such hepatite layer because the release of polyacrylic acid from the GIC lowers the pH and inhibit the formation of hepatite. Thus, it's necessary to develop bioactive GIC that can increase calcium and phosphate ion release. Well, basically, the aim of the study was to fabricate nanosized GIC powder formulation modified with TTCP and HAP and investigate its physical, chemical, and mechanical properties. Well, we divided the objectives into two. First was to synthesize nanosized GIC powder and assess its chemical and physical properties. In our next objective, we modified our nanosized GIC powder and with HAP and TTCP and investigated its chemical, physical, mechanical properties, and we compare it with commercially available conventional GIC formulation. Well, hypothesis of our research was to fabricate the nanosized GIC powder will result in distinct elemental composition, phase analysis, and particle size distribution compared to commercially available conventional GIC formulation. The modified nanosized GIC powder will result in significant improvement ion release, mechanical strength properties, and will shift the pH towards more neutral environment. So here is materials and methods. Well, based on our first objective, we fabricated nanosized GIC powder using sample melt quenching, and two-step ball milling procedure has been proceeded to decrease the particle size of our material. Then chemical analysis such as EDX, XRD, and FTIR has been employed. As a physical analysis, we use particle size analysis and scanning electronic microscope to confirm the presence of nanoparticles in our material. Well, the next is, well, based on our objective 2, we modified our GIC powder with calcium phosphate and investigated its chemical properties, which is EDX, XRD, and FTIR. Then we employed SEM, initial setting time, pH, and ion releases such as calcium, fluoride, and phosphate. As a mechanical strength analysis, we used compressive strength analysis. So here is how we used to fabricate our material. So silicon oxide, aluminum oxide, calcium fluoride, P2O5, and calcium oxide has been mixed, and we place it in an electric furnace, and we melted up to 1,250 degrees, and we hold for 2 hours. Then we rapidly quenched our material into cold water. Then, in order to decrease the particle size up to nano, we used ball milling procedure. In the first step of the ball milling procedure, we used the sieve with the mesh size of 106 millimeters. Then we used we set up our machine for 300 RPM for 2 hours. And we mixed 1 gram of our powder with 10 gram of zirconium balls. And the jar capacity was 50 ml. After that, we proceed with the second step of our ball milling procedure, which is where we use zirconium balls with the diameter of 0.5 millimeters, and we grind it for 300 RPM for 2 hours. Then we used to analyze its chemical properties, which is, I have already mentioned, EDX, XRD, and FTIR. For physical analysis, I proceed with PSA and SEM to double confirm the presence of the nanoparticles in my material. Then I modified my fabricated glass ionomer cement with calcium phosphates, which is TTCP and HAP. To mix the chemical compounds, I used multi-purpose grinder for 3 minutes to apply consistently the force and time. As you can see here in the table, we can see the groups we have. We had in total 7 groups with different compositions of TTCP and HAP. And group A, we used as a conventional glass ionomer cement. We used as a control. After modification of our material with calcium phosphates, we evaluated its chemical properties, then physical properties, then mechanical properties. Well, statistical analysis has been evaluated using one-way ANOVA with 2-key HSD post-hoc analysis, and data was found normally distributed. Here we can see the results of my study where we fabricated of our nano-sized GIC powder. Here we can see the particle size analysis here on your left hand, we can see the particle size analysis before proceeding with ball milling procedure. Here on our right hand, we can see the particle size analysis after first step of ball milling process, which revealed to 224 nanometers. However, here, after first step of ball milling process, as we can see, the particles has been distributed not homogeneously. Right? Then we proceed with the second step of our ball milling process, and as a result, we can see that we evaluated different batches, and from different batches, we got the mean 95 nanometers of our particles. Well, here is the results of our commercially available glass ionomer cement, which revealed to 69 nanometers with 100% of homogeneity. Well, based on the ISO standard, we cannot rely on only one PSA analysis and say that this is nano-size. We have to double do additional tests like microscopic analysis. So we proceed with FESM analysis. So FESM analysis revealed 80 nanometers of our particles. On your right hand, it can be seen. On your left hand, we can see the size of the particles of the commercially available glass ionomer cement. Here we can see the chemical composition of our commercially available product and our synthesized glass ionomer cement. Here, I think the main difference we had, and it might be one of the limitation of our study, that in our fabricated glass ionomer cement, there are no heavy metals, which makes our material less radio opaque. So in commercially available product, we can see that there is strontium ion, strontium heavy metal has been incorporated as a to increase the radio opacity of our material. Then here we can see XRD analysis of our material and commercially available GIC. Here, as you can see, so based on the literature, so there is only silicon oxide can be evaluated based on the peaks we had in our graph. So here we can see FTIR analysis of commercially available GIC and fabricated GIC. And here as well, we can see no significant difference between commercially available product and fabricated GIC. Now we can see the XRD EDX analysis of different groups. This is based on our objective 2. As you can see, group C, which was consisting of 10% of TTCP and 0% of HAP, and group G, which consists of 0% TTCP and 10% of HAP. Here there was higher, as you can see in group C, there was higher calcium and phosphate ratio. It revealed to 2.1. However, in group G, where it was consisting of HAP, it was 1.7. So it can be easily understood that based on the chemical composition of TTCP, calcium and phosphates ratio, it is 2, and HAP's calcium and phosphate ratio is 1.67. So that's how we can prove the presence of calcium and phosphate based on our EDX analysis. Here as well, in XRD analysis, we can confirm the presence of HAP and TTCP in our different groups. FTIR analysis also provided the comprehensive analysis of different materials. So peaks here, they show the presence of phosphate ion in our material. So here we can see the analysis of the powder of our material. These here are the different materials we can see under the SEM analysis, and we proceed with porosity analysis using ImageG software. As you can see that group C, which consists of 10% of TTCP, the porosity area was 50%. However, group G the porosity area was 41%. So porosity can be easily like connected with the compressive strength analysis of our material. When porosity is higher, the mechanical strength of our material has been decreasing rapidly. Here we can see the porosity, the results of the porosity in different groups as well. So here we can see the initial setting time analysis. Well, based on the ISO standard, the initial setting time of our material should be from 90 seconds up to 480 seconds. We can see that group B and group F and G, they are among the ISO standard. However, group C, D, and E, it is a bit higher than ISO standard. Here we can see the statistical difference between our different groups. Here we can see the pH analysis of our different groups. We can see from here that the modification of GIC showed a significant difference and shift in initial pH from acidic to more neutral. The most acidifying material was commercially available product, which had the lowest pH. So what pH gives us? It makes our material less. It can make our material less like easier to cause secondary carries. Fluoride ion release. Well, if we will be comparing all the commercially available product and all our groups, there was I would say there was no significant difference between the groups in different time points. For all the samples investigated, the quantity of fluoride ion released was the highest after the first day, followed by progressive decreasing in release up to 28th day. Well, here we can see the calcium release, and here we can see the phosphate release. As you can see, the calcium and phosphate ion release has been increased rapidly when we incorporated calcium phosphates, which is TTCP and HAP. Here we can see the mechanical strength analysis of our different groups. So based on the ISO standard, in order to use as a restorative material, the compressive strength analysis should be higher than 100 MPa. However, in order to be used as a liner, the compressive strength analysis should be no less than 50 MPa. So as you can see from here, from the graph, we can say that all material can be utilized as a liner. However, only group F, G, and B, they can be utilized as a restorative material. Here we can see the statistical difference between different groups in the compressive strength analysis. Here we can see how the porosity can be connected with the compressive strength analysis. As you can see, when the porosity is 41%, the compressive strength was 112 MPa in group G. However, when porosity has been increased up to 50%, the compressive strength has been decreased significantly up to 77 MPa, which is group C, consisting of 10% of TTCP. Here we can say that HAP has been increased. HAP was used as a material to increase its mechanical strength analysis. Well, as a conclusion, we can say that nano-sized GIC powder shows variation in chemical composition, confirming the amorphous phase in both fabricated and commercially available products. TTCP and HAP's incorporation in fabricated nano-sized GIC powder prolongs initial setting time. TTCP and HAP integration boosts calcium and phosphate ion release, shifting the pH of our material to more neutral environment. HAP inclusion enhances compressive strength, while TTCP reduces it. All are effective as a liner material, but only two groups, which are E and F, are suitable for restoration. Well, here are the limitations. The analyzing of porosity in two dimensions may limit understanding of volumetric characteristic and spatial distribution within the cement matrix. Using a single sample size might not capture the full variability of cement's characteristics. Well, future recommendation for porosity assessment, it is recommended to utilize advanced techniques like mercury porosimetry and helium pinometry, offering insights into 3D distribution and structural integrity. Conduct bonding tests to evaluate the effectiveness of fabricated nano-GIC powder modified with TTCP and HAP, aiding in understanding adhesive capability for diverse application. And of course, it is recommended to evaluate the materials by activity with SBF. So I think that's all from my side. If there are any questions, please feel free to ask me.
Nazim, thank you so much for your research, for your presentation, and also for Sam for his contribution in this conference.
Yeah, thank you, Prof. Thank you too. Thank you so much. Thank you for inviting me.
Welcome.
Can I just say, Nazim, it was a very nice presentation and you did a great job. And thank you again, Marian, for giving a place for Nazim. And so he's up and coming excellent researcher. And thank you very much. Thank you.
Thank you, Prof. Thank you so much.
Really, is an excellent research. Please tell me, you are available today for conclusion of the day?
Yeah, sure.
Yes?
Yeah, of course.
Sam?
Come again?
Marian, it's very late in the night here. It's like 1 o'clock or 2 o'clock. What time is the conclusion?
Just a moment.
It's because it's now, if it is
Câte e asta?
1845.
Hmm?
1845.
1845, see it.
1845, that's 19. So it means 19 is 20, 21, 22, 23, 24. Okay. It's about 2 o'clock in the morning here in Hong Kong. So it's very, I was not hoping to be, yeah, it's very late.
Some is difficult for you. I request this to Nozim to conclude the day.
It's okay. It's okay. I can.
It's okay, Nozim?
Yeah, it's for me. It's okay. It's fine. Yeah, it's fine. I will be attending.
Thank you so much.
No, Nosim is in Europe, and I'm in Hong Kong. So it's like for me, it's like
no problem, Sam. Many,
I'm
many
really sorry,
for your,
Marian. Yes.
attendees and for your invaluable help. Thank you, Sam.
Yeah,
Okay,
thank you,
okay,
Prof.
thank you.
Thank you.
Thank you, Marian. Also, thank you, Nazim, for taking this over. Thank you so much.
Yeah, thank you, Prof. Thank you.
Good day.
Hello, can everybody hear me?
Yes.
We have some technical issues regarding the attendance of the next presenter. We'll be taking a 5-minute break, if that's okay, Mr. Marian.
It's okay.
Okay, thank you very much.
Hello, good morning.
Good morning, Gaetano. Hi.
Hi, Mario.
Thank you for coming. Thank you for your help. Next speaker is Professor Gaetano Isola from University of Catania. His topic is multidisciplinary treatment of periodontitis patient in the new era of clinic and research. Please, Gaetan.
Thank you, Marian, for this kind introduction, and thank you for both of you, Professor Samanarayak and you, for this kind invite. For me, it's a great pleasure to be here in this important congress with some international speakers. I am Professor Gaetano Isola, and I'll try to share my screen. Just a moment. I will try. I'm trying to. Okay. I hope that this is fine. It's a great pleasure to be here. I'm assistant professor, I'm associate professor of periodontology at the University of Catania, Italy. And today I will present some.
Excuse me.
Yeah.
Sorry for interrupting. We cannot see your presentation. We can only see the Google Meet. You share the Google Meet.
Just a moment.
Conference.
I will try to.
You can present now and share the entire screen. Is the third option. And then you can open your PowerPoint presentation. Doing this way.
Okay. The full screen.
Yes, the entire screen.
The entire screen. Now, how is you can see?
1 second. Yes, we can see it.
Okay. This is the full screen of the presentation.
Yes, it is in full screen.
Okay.
It's working. Thank you.
No, it's okay. Thank you. I am associate professor of periodontology at the University of Catania, Italy. I work actively with several colleagues of my institution in periodontology, and thank you again for inviting me to this great congress that is held every year online. I will talk this morning about how is important to treat patients with periodontitis and how is important a multidisciplinary treatment of these patients with periodontitis that is not only focused on the periodontium, but usually the patient with periodontitis has several systemic link, and we will talk about how is important to control this kind of link between oral health and systemic health. Today we will talk about the detrimental effects of periodontitis, maybe linked with the initial stage of disease like gingivitis and periodontitis. Then we will talk about important to the management of the oral microbiome, this kind of patients, and then we'll remove this. And then we will talk about the systemic interaction between periodontitis and systemic disease, and how we can do a proper minimally invasive treatment in order to reducing also the systemic impact of the treatment of periodontitis. As we know, periodontitis is a multifactorial inflammatory disease. It is a really complex disease of bacterial origin, and how is important that we should treat this kind of disease in the early stage of disease. This was a patient that referred to our unit of periodontology before the COVID appearance, and as we can see, she come with a reduced and an important alveolar bone loss and tooth mobility on several teeth on this on this mouth. And if you can see, this is a patient of 23 years old with no systemic disease, no smoking, and the main problem of that patient was the late diagnosis of periodontal disease, and this should be the main problem. And in such case, what is the cases? Because as we can see, there is no huge amount of periodontal plaque, no amount of other problems. And in such case, as we know that the early diagnosis of diseases is really fundamental for the then treatment. In order to treat this kind of patients, we have to push back our mind and to think about the importance of the microbial ecology of the oral cavity. As we know, the oral cavity to represent an open system, ecological system, in which we will find some microorganisms organized in oral biofilm. The oral biofilm is a complex organization of oral bacteria that are protected by several things, and now we will talk about it. And these kind of bacteria are embedded inside to the oral environment. That should be important also to know, especially in the late part of the treatment, because the only oral biofilm cannot allow the destruction of periodontal tissue, but the periodontal tissue destruction is mainly due by the host immune response that in some patients that are predisposed to disease starts the really important thing about the periodontal destruction. The other important things that about the patients with periodontitis that usually the patient has no clear diagnosis, and they don't know how they have the destruction of their own gums. As we can see in this case, we can see maybe a patient with healthy gums, but with a simple exam due with a colorant of a plaque, we can know that the periodontal disease is important in the different things like maybe tooth malposition or presence of calculus or something else, in which we can see that is not in the full mouth, but when we refer the periodontal disease, is a disease on the single periodontal sides. As we can see, there is a huge amount of dental plaque in specific sides of the mouth of the patient. And when we treat a patient with periodontitis, it is important to know that the really treatment should be done on the single sides, on the single periodontal sides. Usually, it's important to know that the first stage of periodontitis is already done by a dysbiotic bacteria, and that is followed usually by an uncontrolled inflammatory response that is mainly due to a low chronic infection on periodontal tissues, in which we have the colonization of the biofilm. On the colonization of the keystone biofilm pathogens is followed by the release of several inflammatory mediators that starts the initial part of the connective tissue destruction, and then followed by the alveolar bone remodeling in a bad way. In such case, the most important things should be done when we treat a patient with periodontitis is to focus on the characteristics of neutrophils, macrophage, and dendritic cells, and other keystone inflammatory mediators that starts to fight with a dysbiotic microbial community. And in such case, in the first stage of disease, it is important to analyze the activation of the acquired immune system in the predisposed bacteria. In the first stage of disease, we will see that there is a movement from the healthy condition to the gingivitis condition, in which there is the first release of the several acute inflammatory process and several inflammatory biomarkers that starts the invasion inside to the bacteria and to the periodontal pockets, and with some pro-resolution mediators downregulate the recruitment of some immune cells and uptake of several neutrophils that start the inflammatory lesion. When we refer with a patient with periodontitis, this is the main part to treat the disease. Usually when the patients come to with advanced destruction of periodontal tissue, and we have to think that the most important thing is to treat a periodontitis when it starts directly with the gingivitis, because there should be no periodontitis without any gingivitis states of the disease. Then the most important thing, unfortunately for our patient, is the second stage of disease that I underline that is important. This kind of patients, the predisposed patient to disease, there is a movement from gingivitis to periodontitis. In such a phase, already there is no strict consensus how should be the first mediators of the destruction of periodontal tissues, and in such case there is a really immune response that involves both innate immunity players that starts the subclinical destruction of periodontal pockets, because in such case the patient don't have specific symptoms of disease, but usually is underlined in a specific way. Then there is the third stage of disease, in which we have the periodontitis, and there is the release of several pro-revolution mediators with the main activity of the lymphocytes T and B, and there is a physiological reaction aimed at protecting the organism against the specific periodontal bacteria. And such case is important that should be controlled, maybe the release of the lymphocytes B and T. Then we know that usually the inflammation from periodontal disease move from the periodontal tissue directly to the systemic one. And in such cases, it's important that patients with periodontitis should be controlled not only from the oral inflammation, but also on systemic one, in which there is the release of several inflammatory mediators, some of them that are shared with certain systemic disease, with cardiovascular disease, diabetes, and something else, in which there is the release of C-reactive protein, fibrinogen, serum amyloid, and should be this kind of disease affect several other apparatus like the gut microbiome with the dysbiosis, the liver, the heart, and also the preterm in certain patients. In this case, as dentists, we have to put our attention maybe to find some biomarkers of disease. And one of them, it was shown by the study of Pan and Ayud and colleagues, that found that in the blood, if we have a CRP values above 3 milligrams per liter, from 3 to 10, we have to put our attention to about the risk that the patient has not only on their mouth, but also on the systemic apparatus, maybe the cardiovascular disease and the other ones. In such case, a mechanism of bone loss should be also correlated with a specific balance. It was a study that we performed several years ago on the positive correlation between the Rankolo OPG ratio and periodontitis patient, in which we have to know that also the bone activity in our periodontitis patient should be not perfect. However, the main issues about the periodontitis, that from a systemic point of view, should be an unbalanced oxidative stress pathway status, and this should be the main pathway that should be underline the role of periodontitis and cardiovascular disease, or maybe periodontitis diabetes, in which we have found in several studies that we have performed on blood and on saliva, that there is a specific different oxidative stress pathway of patients with periodontitis that's really common, maybe with some certain activity of endothelial dysfunction. In such case, the periodontal inflammation and systemic risk should be done by the release of several inflammatory cytokines and the genetic susceptibility determinants. In such case, the research on periodontal disease is too preliminary. We don't have specific guidelines of specific studies that found some genetic polymorphism of patients with periodontitis, but the most important thing is to control the bacterial burden, that if we resolve and reduce the huge amount of bacterial burden on periodontal tissue, as for sure we can control the release of the inflammatory response. For this, we have to underline the important thing of the gingival biofilm, that is a complex organization of microorganisms that with a specific complex biological interaction and the presence of polysaccharide extracellular matrix control the whole organization of the biofilm, especially for specific antibiotics or anti-inflammatory components. And if we have to know that we should treat periodontal disease, we have to disaggregate this biofilm organized in a specific thing. In such case, I had the honor to work with Professors Sigmund Sokransky and Professor Ray Williams that study for over 40 years the huge amount of periodontal tissue organized in a specific biofilm that is totally different from the supragingival biofilm to the subgingival one. They found a specific pyramids, the Sokransky pyramids, in which they analyzed the specific bacteria, the red complex, in which we found P. gingivalis, Bacteroides faucitus, and Treponema denticola, and also the orange bacteria that are more virulent and they have the ability to disrupt the periodontal tissue. And we have to know that in the supragingival plaque, unfortunately, we have some certain periodontal pathogens that they are really low activity on periodontal destruction, instead of the subgingival biofilm, in which we find the complex of orange red bacteria that mainly determines the periodontal tissue destruction. As we know, there is totally difference between the supragingival biofilm and the subgingival biofilm. This picture should be translated into the fact that if we would like to treat a patient with periodontal disease, the main thing is to treat the subgingival biofilm. We have to focus our attention as a clinician to find the subgingival biofilm, because the presence of specific pathogenic bacteria, this is the model developed by Roy Page and Kenneth Corman in the 1997. There is the release of the antigens and lipopolysaccharide bacteria that determines the host-immune inflammatory response, the connective tissue destruction, and the expression of the disease and progression, in which there is a specific negative circle, and that determines the clinical aspect of periodontal disease. Moreover, we have to know that patients with periodontal disease, these are the study of Riccardo Teres, that was also an alum from Professor Sigmund Sokransky, determines that the patient with periodontitis has a specific a range of bacteria from the quality and the quantity point of view. And we have to know that patient with periodontitis is a specific cluster of bacteria that is totally different from a healthy patient, and we have to focus our clinical attention. Also because the periodontal activity is really determined to periodontal dysbiosis and detrimental effects of not only in the mouth but also in the gut. When we treat a patient with periodontal disease, we have to know also that we may improve not only the oral mouth but also the gut, and in certain patient, we have to know that it is important to treat this patient. This was underlined also by Ian Chappell in 2025, in which there was found that there is a movement from the clinical health to periodontitis to a symbiosis, to a frank dysbiosis. We have found also that our biofilm should be organized in a specific cluster of bacteria, and in which there is the movement from the eubiosis to the dysbiosis to periodontitis. There is like a quorum sensing of periodontal bacteria that determine the activity destruction of periodontal tissue. Also, the mainly systemic effects has been underlined. In such case, a study of Montserrat in 2016 found that periodontitis is linked to over 57 systemic disease. In such case, we have to know that many of clinical trials in the last decades study the impact of periodontal in systemic disease and found several diseases linked with periodontitis. And as we have to know that there is a specific increased trend of systemic condition and periodontitis, this increased during the last years. In the over the 30% of periodontal literature now study the effect of periodontitis and systemic disease. The mainly activity and the mainly disease related with periodontitis has been found like the cardiovascular disease. Maybe we have found atherosclerosis, coronary disease, hypertension, myocardial infection, and other diseases that could be really determine the impact of the quality of life in our patient. Because there is a specific impaired endothelial dysfunction, the patient with periodontitis has a impaired arterial stiffness, and also the thickness of the carotid intima media and the calcification score that is really impaired compared to healthy patients of people without any inflammation. And the inflammation should be determined as a low increase of cardiovascular disease through the mechanism. One is the direct mechanism, in which we have the ulcerated periodontal pockets that enter to the periodontal bacteria, and then the systemic circulation and the subclinical risk of periodontal disease. And then through an indirect and indirect mechanism, there is the possibility to determine the increased level of inflammatory mediators, and then determine the systemic inflammation. In such case, the role of inflammation is important. This we have to know that from the second part of my speaking. Control the inflammation is really important to improve the clinical aspect of the disease. We found that patient with periodontitis has specific and certain pathways linked with both serum and saliva, with a common sharing things about the inflammation. Another pathway that should be important should be the impact of periodontitis also with microRNAs, that now has really important mediators of several subclinical risk of inflammatory disease. And we have found that patients with periodontitis and periodontitis plus cardiovascular disease has the same common risk and the same common mediators. The message should be treat periodontitis, should be treat also the cardiovascular disease. Also is the same with diabetes. That is important because the reduction of inflammatory mediators of patients with periodontitis and diabetes should also control the host tissue bacteria and related degradation product that should be worsening the status of diabetes patient. Also, we have found several years ago that the main important things of periodontitis and diabetes is to treat the pre-diabetes status. We found that people with periodontitis should have the same systemic status of patient with diabetes. And also, like the treatment of gingivitis, also the periodontitis should be reduced the pre-diabetes status. Is the same with the neurodegeneration. We found the study of Iago and colleagues that also patients with periodontitis has the high risk of severity and the possibility of develop some neurodegenerative disease like Alzheimer's disease on the other ones, and also treat patients, elderly patients with periodontitis should be reduced the risk of the worsening of Alzheimer's disease. We have found also that, like we have talked about, the link between oral and gut microbiota in periodontitis patients, and as we know that we have to focus how they are the objective of periodontal treatment. What be our goals in a periodontal patient, what we can do for our patient. One should be disrupt the biofilm, because we have talked that it is a complex organization of bacteria. Then we have to reduce the subgingival pathogenic microflora, and with the related thing of the control of the inflammatory and host response. But the main problem should be the prevention of the subgingival regrowth of gingival tissue, because we know that it is quite impossible to eliminate the gingival bacteria, but we have to control the appearance of the bacteria that are present in subgingival biofilm. For this, important things is that should be released the guidelines by the European Federation of Periodontology, in which is important the periodontal treatment, and we have to reduce the proportion of microflora from a compatible one to a really reduced number sites of periodontal activities. Moreover, we have found with the colleagues of Giovanni Salvi, Klaus Lang, and Tony Sculian that is important the role of non-surgical periodontal treatment in this kind of patient, and we have a critical point of probing depth of over 3 millimeters should be determined as an high risk to the further develop of periodontal disease, maybe in the treatment of surgery approach. The first thing is that we have, when we found the endpoints of successful periodontal treatment, is a correct non-surgical periodontal treatment approach that should be done on the lateral aspect of the ultrasound instrumentation, and we have to spend a lot of time. I prefer usually to do the quadrant scaling root planning, may be translated now in the quadrant subgingival instrumentation, and we have to focus the attention on specific instrument. We have also find some adjunctive agents. Not only are important the ultrasonic instruments, usually are fundamental the manual and hand instrumentation done by the curettes, the crazy curettes, but the important things is also to diagnostic probably the periodontal disease, because the presence of probing depth of over 5 millimeters, this is a study by Werog on the 1978, should be found that patients with probing depth of over 5 millimeters should be reduces the efficacy of non-surgical periodontal treatment. This should be translated into the fact that patients with important pockets should be then treated by the surgery. It is important to note that the classic periodontal treatment, mainly by hand and in ultrasonic instruments, should be reduced only the 70 and the 40% of the bleeding on probing. This should be, and not only, but also the calculus, they should be reduced from the 5 to the 60%. And for this reason, we have developed several operative strategies in which now we will focus our attention on the minimally invasive approach that should be usually performed by minimally surgical, minimally non-surgical, but especially surgical approach. It is important to know that when we'll talk about the minimally invasiveness of both non-surgical and surgical periodontal treatment should be defined by specific control of the edema, pain, inflammation. There is a reduced risk of also flap recession procedures and something else. We have found in a study several years ago that a minimally invasive approach is important also for the non-surgical and surgical periodontal treatment, and this kind of approach should really improve our outcomes, our healing outcomes in periodontitis patients. This should be performed by different things. Once it was developed by Professor Leonardo Trombelli with the single flap approach, in which we'll find the treatment of patients with infrabony defects on the vestibular aspect, and the other one, it was the modified minimally invasive surgical approach developed by Tonetti and Cortellini, that found how it's important to prevent the presence of papilla and the environment on the periodontal infrabony components into a successful treatment of patients with periodontitis, maybe with the strength use of the matrix protein derivatives and also specific bone. These are the results that we have performed on patients with infrabony components. We have published several years ago with the successful results of these patients with a 5 years follow-up. Now we have found that a minimal invasive approach in specific patients with periodontitis, especially with infrabony components, should be improved the quality of patients. Also because the most important thing is the last part of the periodontal endpoints, that is the periodontal supportive treatment, and it is important that not only the proper treatment by the dentist, but the control of the oral hygiene, to avoid smoking, to have a specific balanced diet should be also improve the outcomes that performed in the periodontal chairs. Mainly because the patient with periodontitis should be also treated when the case is really balanced and with a reduced amount of dental plaque, also with implant approach that should be performed in a safe way with the low risk of develop of periimplantitis. These are the results of our study, that with the 5 years follow-up, we found that also patients with a minimally invasive approach should also develop in implant dentistry. Mainly because we have found that professional treatment and a minimal invasive approach should reduce the release of certain cardiovascular disease outcomes. And for this, important is to treat with a minimal invasive approach these patients. We have to conclude that in our experience, the main problem to treat periodontal patient is to reduce the periodontal pathogenic bacteria, and especially with the K factor in the early stage of periodontitis. The most important things is to properly treat patient with a non-surgical periodontal approach that should be mainly performed with a quadrant-wise approach. But the most important thing is that in the non-surgical periodontal treatment should be performed by skilled people with the use of hand and ultrasonic instruments, and also to dedicate time for a proper treatment. We have to know that maybe a treatment of a single quadrant should be over 40 minutes, because the quality of our treatment is really linked to the time that we have to dedicate to our patients. We have found that other adjunctive adjuvants like antibiotics, systemic and local one, we avoid the use of lasers. Maybe the use of erythritol or something should be only part of the non-surgical periodontal treatment that should be mainly performed by the use of only hand and ultrasonic instruments. But we do know that in such case, the step 3 of periodontal treatment now would become fundamental. It should be performed in sites that are that they has the presence of deep pockets of over 6 millimeters with probing depth of or in a pockets of 4 millimeters, but with bleeding on probing. In such case, usually the patients move to the surgical approach, in which is important to know that we have to correct the bone defect with a specific treatment. And from the data that we have in literature, that we don't have a single specific therapy in our patient, but should be personalized our approach to the single patient. Our objective are surely to reduce the number of periodontal pathogens. We have to try to modify the habitat of our periodontal environment, and we have to think about how to modify and control the chronic inflammation, because when we try to lower the pathogens not only in this site, but we have to focus to not treat non-diseased periodontal sites, because treat a non-diseased periodontal sites by specific and ultrasonic instruments should be also start some periodontal lesion. But the most important thing in our patient is to start and to specific prepare supportive periodontal program in which we have to specific to personalize our approach in patient periodontal disease. The most important thing, however, is a specific periodontal approach. And for the future, maybe we know that we should treat patient with prebiotics and probiotics. At this specific stage, we don't have specific and certain guidelines on the treatment of prebiotic and probiotic in our patient. Also, maybe some good news should become by pro-resolving mediators, in which are linked maybe with a specific diet approach, and should be find certain good anti-inflammatory effects, especially when we compare it to NSAIDs or other systemic drugs that has a really important systemic impact. And then in the future, just for sure, the epigenetic therapy will determine a change in gene expression, and maybe we could follow and we could find some most important things about the epigenetic therapy, but the research in such case is too preliminary to be draft specific conclusion. Just for sure is important that maybe also the stem cells in the future could be help ourselves. Surely we have to move for the find of very biomarkers of periodontitis, and the new challenge should be start on studies on large number of population through a non-invasive approach, and in such case the study of salivary mediators, but specific gingival clavicular fluid mediators should help us in a proper treatment of periodontitis. We have to know that the treatment of periodontitis should be also change our patient, and we know that also periodontal treatment should improve the quality of life in several patients, as we can see. I would like to thank you, Professor Constantinescu and Professor Samanariake, for this kind of opportunity. I invite you to visit our region, Catania, that is beautiful, especially now that we are in November. This is our university. This is located in the center of Catania. And thank you again for this great opportunity. And thank you for all of you that were here to answer me.
Thank you, Isola, for your contribution and for your very interesting presentation. Thank you so much.
It's a pleasure.
Hello. Hello, Gabor. Next speaker is from Budapest, Dr. Gabor Herman from Semmelweis University. He present
We cannot hear your microphone, Professor. Professor Herman, you're gonna need to unmute yourself.
Dr. Gabor present paradigm shift in orthodontics. Please, Gabor.
Okay, thank you for the invitation, and let me just grab my screen sharing. Here we go. Can you see my screen?
Not yet.
No, we cannot. Can you try again?
Okay, so
When you select present now, you have on the top row entire screen. After that, you can select screen and share.
yeah, I did it before, so this
Yes.
is, I'm wondering why it doesn't work. Okay. Present now. Window. Okay, can you see the presentation right now?
We can see the meeting conference because you selected the window tab in Chrome. If you have a presentation as an application, like a PowerPoint, you can share your entire screen and then open the PowerPoint presentation.
I did it, so this is why I'm wondering why it doesn't work. So
If you selected to share the entire screen, then please open the presentation. I mean, select the program.
so this is what I do. Do you see my presentation?
No.
No, we can only see your Chrome tab.
Okay. Okay, so I go back to. Sorry for that because I'm not so
No problem.
You can stop presentation for now. Yes, stop presenting.
Press it. Yes, press that button. You can select.
Now press again present now.
Yes.
On the top row, you have Chrome tab, window, and entire screen.
Okay, entire screen.
Select entire screen. Select the screen and press share.
Okay. System preferences.
Oh.
Can everybody hear me?
Yep.
Dr. Gabor Herman just left the meeting. We'll be waiting for him to rejoin. Welcome back, doctor. Your microphone is muted. You need to unmute yourself so that we can hear you.
Okay.
We can hear you now.
Okay. Again, the entire screen.
Yes.
So how about now?
Once you press entire screen, you also have to select the screen. Okay, now we can see.
Okay, now we can see it. And it's the presentation full screen. You may proceed.
All right. Okay. Thank you for your assistance. Okay. So thank you very much for the invitation again, and sorry for losing some time. And just let me get in and start the presentation from that point. Paradigm shift comes with understanding of the need of paradigm shift. So I would like to step back and use this quote and just look at what we call orthodontics from a different perspective. And many years ago, this TED talk made a huge impression on me. Because this person is called Simon Sinek, and the presentation is called The Golden Circles, and it was really impressive and fantastic to me, and it helps to understand everything in my life. So this method I use for my personal development, for my business, for my practice, for my treatments. And it's a very simple approach. So if we do something, do we know why we started to do this and how we apply the knowledge to achieve the final outcome, the practice, what we do? So I try to use this analytic mind in the upcoming couple of minutes in my presentation. And I use it because definitely we can say the long history of orthodontics has given beautiful smiles to patients and people all over the world. And using all the tools what we have at the moment, we can say we are specialists of what? So we have seasoned beautiful appliances, tools, microimplants, three-dimensional planning, three-dimensional appliances. So we are perfectionists on how to put a tooth from one position to another, how to put the jaws from one position to another. So we are specialists of what. But in order to get answers from ongoing and never-ending debates, I would like to step back and use filters to ask again the whys. So this is how I structure my lecture today. I would like to get into the problem first. Maybe you find it a little bit provocative, and then I will build up why I think a new paradigm is necessary in the orthodontic specialty. So when we go to the, in order to understand, like I would say differently. So in order to understand if there is a problem, I would like to ask you just put the perspective into the patient's perspective. So if there is a patient in the age of evidence-based medicine, and there is a profession which has 120 years of age, so we expect that, so when we try to imagine something like 120 years old, so this is an old professor, just a Buddhism monk, or a beautiful library, old university, and library with beautiful books and with all the knowledge. But concluding, so there, the perspective, from the perspective of the patient, we believe that there is a codex. There is a big book, contains all the knowledge specified to every problem that can happen in the orthodontic specialty. And this is exactly how a patient believes that this profession is based or founded by. And when the the patient goes to a specialist, we expect that I have a different specific problem, so there can be an answer in this codex for that specific problem. So if it is really true, so we need to get back and analyze the definition of the orthodontics. And when we look at the definition, we will find that we move teeth and bones, we treat formations that are called malformations, jaw malformations, or dental malocclusions, and we can specify based on the practice that we deal with local issues. We look at these kind of problems like isolated, and mainly we use as a problem cause the genetic inheritance. And when we look at the malocclusion, we look at this as a potential pathology. So these are the three principles that specify or qualify the current contemporary orthodontic specialty. But if we go deep in, let's say, 6 steps, and we just try to dig into the perspectives or the qualifications of the orthodontic specialty, first we should talk about the phenomenon called evidence-based orthodontics. And the movement started back 10 years ago, more than 10 years ago. And by this time, or at this time, even we thought that we are very close to say this is an evidence-based profession, this is evidence-based science. But when it comes to the everyday situations, and we are just faced by a situation like this, it's overjet, class 2 malocclusion, and then it seems that there is a big debate on how to approach. So one orthodontist will say this is an extraction orthodontics of the maxillary, premaxillary, premolars, or surgery, or distalization, or clastoelastics, or non-extraction by moving the jaw forward with either type of alternative approach. So there is a big serial mixture of different kind of opportunities. And it is an ongoing debate, very similar to the early treatments and all the other ongoing debates in the orthodontic specialty. And it seems like instead of professional evidence, we form groups. So there are academic schools led by different professors, and there are going to be distalizers, extractionists, non-extractionists. So it is like fans of different clubs and groups. So we are fighting with each other with ideas instead of saying which is evidence-based or which is not evidence-based. But when it comes to the evidence-based question, I would like to get back a little bit, because by the definition of the medicine in general, we say medicine is formed by understanding of the etiology, formed by diagnostics, and then the treatment comes. So before we start collecting evidences about how to retract teeth in an extraction and how to distalize teeth, which method is better than the other, but we have to get back and ask if the diagnostics and the diagnosis itself and the etiology is really evidence-based. And I still use this book because so far this was the only that tried to collect the actual evidence-based information about the orthodontics. But I have to say there is no even a chapter about diagnostics and etiology of orthodontics. So how can we talk about evidence-based orthodontics if there is no evidence-based information about how the formation of the problem started and how should we diagnose it on an evidence-based manner? So this is a big question to me. How can we talk about evidence-based medicine if there is no answer for whys and hows? And if you go back to the second approach, let's look at the contemporary diagnostics. So the contemporary diagnostics is based on the local phenomenon. So we say the orthodontic malformation, the jaw malformation is not in a relationship to the surrounding part of the or the total human body. And we form these kind of diagnostics to achieve stable results. But when it comes to the reality, we know that based on Bob Litter's investigations, nothing is stable. So we have to put patients on lifelong retention. We go further and we try to understand again these kind of features like local, genetic, and pathology. But again, so what do we treat? We treat malformations. And most ideally, if there is something called mal, there should be a definition of norm. Of course, on an anatomical way, we can describe norm, but what really norm is. So like does angle 1 relationship prevent temporal and joint disorders? Does angle class 1 prevent periodontal problems or speech problems? And vice versa. So if there is a class 2, is it really obligatory to have consequences later on? So the problem is that there is no information about the norm is protective or preventive to any potential problem. So malocclusion is not really a pathology. So the question is, why do we use this kind of classification? Of course, from the aesthetic perspective, there is an explanation, but from the functional perspective, we are lacking the information that would support that class 1 is the ultimate goal from the functional perspective. And when we go to the risk management perspective, from the ethical and medical legal perspective, the do not harm principle of medicine is that if there is a problem, and in our case it is malocclusion or malformation, and there is a potential treatment, of course the treatment should not bring more harm and more risk to the patient than the lack of the treatment. And we cannot say, because if we are not able to support that malocclusion is a pathology, and we contrast it with potential risk of tooth extraction and orthodontic surgery, so certainly the risk-benefit ratio is going to be a little bit disturbing. So this will bring that the intervention itself has a higher risk to the health of the patient than the lack of treatment. And what do we say about multifactorial origin? And I ask it because still in the profession, many colleagues, I would say, still this is the majority of the people thinking that we look at malocclusion and facial malformations as a singular or dominated genetic situation. But after all, even in the textbooks, we say there is a multifactorial origin. So not only the genes, but all the other factors, including the environmental factors, are playing role in the development of the problem that we see. So this is the same for the relapse. So there are not only genetical patterns in the relapse, but all the other multifactorial situations. But how we treat patients based on the structural approach, based on the principle that it does not relate to any environmental factors, muscles, breathing, tongue posture, but we use this as an excuse. So when we fail, we use excuse as an excuse that, oh yeah, it was multifactorial. So it is, we don't use multifactorial principle as it should be used. So what do we think about teamwork and the relationship of malocclusion and the treatment to the entire body? So we claim that malocclusion is isolated, and we do is what happens in Las Vegas, it remains in Las Vegas. So what we do it in the stomatognatic system, it does not have any effect on the entire body. There is a contradiction. So if I look at this, oh, sorry. So if I use this publication from 2012, and it investigated the effect of cervical headgear on the cranial base, and it says very significant changes took place on the cranial base. So it is not so distant effect, but very significant. So it is not only as effect on the maxillary and mandibular position, but much more disturbingly on the cranial base. So we should not say we do not have any effect further than the maxillary mandibular dentition and deposition. And if we conclude, I repeat again, this is maybe people will find it provocative, but I would say, in order to highlight the problem, this is really, as it seems from an outsider perspective. Just look at the patient's perspective. It's like you go one orthodontist, and the diagnostics and the treatment plan is one or A, and you will find B, C, D, very, very different and contradictory opinions. So we form clubs. We have gurus that we follow, or academic schools. We create results which are unstable unless we put retainers lifelong in the mouth. There are multiple opinions from the same practice, and we don't have best practice as we believe that we should have. And so the treatment plans are dependent which orthodontist we visit. So from the patient perspective, it is very disturbing, and we definitely sacrifice teeth and jaws for treatments that bring more harm and more risk to the patient than the lack of the treatment would. And this is something that makes me, at least, believe that that we call it a freedom on the one hand, but I think this is something that we should not call an evidence-based science, because if everything is possible, nothing is evidence-based. And then this is time to figure out what is the reason why we cannot find the answer in a subsystem for this kind of ongoing questions: extraction, non-extraction, early treatment, and so. And from that perspective, if we look at the debates, so there is a kind of aligner war. So aligner is very recent. Align Tech stated that orthodontic braces are not needed anymore, which induced outrage in the specialty. But general dentists are taking a huge role in orthodontic treatments on the market. There is a claim that industry is taking the education, misleading professional opinions, and people are learning not from the academic schools anymore, or not only, but from the study groups. And non-extraction, early treatment, myofunctional orthodontics are all over-debated areas still, and the sleep medical invitation that we should take place in sleep treatments are rejected, because we claim that it is not related to the jaws and the teeth. So there are many questions, big questions, that are present in the orthodontic specialty. And again, so how should we protect ourselves? And the best protection would be to have an evidence-based orthodontics that say, this is the science, this it protects and it supports the idea what we have. So it seems that people from the conventional treatment, they go more for cosmetic. From fixed bases, they go to aligners. So we seemingly lose a big market share as an orthodontic profession, because we cannot protect the job what we do as a specialist, which part is more professional compared to the one done by non-orthodontists with aligners, for instance. And yes, aligners will bring other challenges. Of course, Smile Direct Club went away from the market, but we should not be naive enough not to think that a new challenger will come to the market soon. So instead of protecting us by protests from direct to us customer aligner or mark companies, we should figure out why orthodontics is different, why the performed treatment by an orthodontic specialist is different from non-orthodontist. So I would like to introduce the new paradigm. So the one that should help us to understand the difference between different orthodontic treatments. So of course, I would like to get back again. The birth of orthodontics was in the 19th, and in the same area, in the same time, the Western medical education and the practice changed by this very historical report, the Flexner report. So we introduced allopathic medicine that works with pharmacological agents and physical interventions. So we became a very materialistic practice of healing. So we believe that the human body is like a working machine, and the parts can be separated from each other. And we try to measure everything in order to decide whether it is necessary to treat or not. So in this perspective, this is very well understood why we talk about mal relationship. We measure structural forms, and we say that the craniofacial part of the human body can be separated from the entire other part of the human body. So we are structural, we treat malformation, we look at the problems as isolated, and we believe that the major cause of the problem is by DNA. But since this time, so we are talking about the early 90s. So since that time, there are so many different novelties, not only in the orthodontic specialty, but in medicine in general. So instead of genetics or within genetics, we are talking about epigenetics. So the growing power of environment. We have technological novelties. There are new techniques. There is definitely a different patient attitude. There are economical changes and changes in medicine. I mean, new medical approaches, functional medicine, integrated medicine, biologic medicine. So there are medical approaches that look at the human body as one. And neuroscience brought so many information. Basic science, anatomy, physiology gave us answer to questions that induces basic teachings to be rethought. And sleep medicine I think it is very important to dentistry in general and fascia research, and we just continue this list. So there are so many different novelties that induces changes, induces at least to step back and look at the problem, what we treat from a different perspective. I bring the genetic epigenetic debate again. So this is huge. So instead of the human genome study that we believe that would give us the answer and bring the answer, so we now talk more about the environmental effect on genes and the effect of genes. So it is not surprising that almost in every chronic disease we talk about multifactorial origin. So there is a congenital cause, of course, but there are environmental factors, and environmental factors in general, in just a broader scope and the closer scope. So like in the orthodontic specialty perspective, lips, tongue, functions, head position, neck muscle functions. So all these functions will induce and play a role in the development of malformations and malocclusion. So this is the reason. So of course we believed when we formed medicine and we just went specialty into specialty. So we hope that there are subsystems with general rules. So we can believe that cephalometric analysis will give us the answer for having some understanding of the subsystem. But the systems are not isolated. So these systems are working together, so they are independent on each other. So this is the reason why we cannot answer, even though we try to make surveys, studies, but we cannot separate the influence of the environment on the malocclusions and malformations. And sleep medicine brought a very interesting perspective, because sleep medicine is one of the medical approaches, the Western medical approaches that are based on team, because of course the sleep physician is the main, the head of the team, but ENTs, psychologists, dentists, myofunctional therapists are also playing in this team. So it is not a unidisciplinary manner, but this is a multifactorial. The sleep is multifactorial, so the sleep medicine is accepting this kind of origin and addresses on a interdisciplinary manner. So yes, there is a huge amount of evidence that dental sleep medicine can help and can play a role in the treatment of sleep apnea and snoring. So it makes sense that the sleep medicine started to approach dentistry, and of course sleep is much more important than malocclusion. So you cannot die in a malocclusion, but you can die in a long-term sleep disorder. So sleep dentistry is an important part of the sleep physician team, and when we use these kind of principles in general in dentistry and in orthodontics, it will induces some changes in treatment direction, in appliance use. So definitely, when we accept that sleep is an important part of health in general and in medicine, so we should address these kind of requirements from sleep in dentistry and in orthodontics from sleep. But what is going on? So if we again, so sleep medicine is very integrative, the way that we accept that this is a multifactorial problem and we should address it in a multilateral way. But when we talk about sleep, we ultimately talk about general health, because as soon as we open airways, make the patient breath better, we improve the sleep quality. Of course, the patient's regeneration will be better. The patient's coping mechanism with any chronic disease will be better. So ultimately, we are improving general health. So this is very important, because not even in sleep dentistry, but in sleep team in general, we have to understand that it is not about airway size, but we are responsible for the general health of the patient. So this is important, because we are DMDs, we are DDS, but now it's making sense that oh, this is why we are doctors. This is why we are more responsible for the patient rather than giving a nice smile. But of course, I don't want to make it minor. So it is very important to give nice smiles to the patient. But I would like to emphasize that it can bring even more than just a nice smile. And when it comes to the medical approach, like this is a medical approach, we have to look at the patient's right. So the medical ethic code by the American Medical Association. So the elective treatment, and orthodontics is an elective treatment, should be based on appropriate information. So the physician's obligation is to present the medical facts accurately to the patient, and the patient's right and responsibility to make a decision. So this is very important, because if we understand that some of the treatments that we proposed in the past or propose in a moment bring higher risk to the patient than the lack of the treatment. This is something very important that we should consider or reconsider, how we force the patient, for instance, how we threaten the patients with potential consequences that are not supported by evidence. So the new doctrine should be based on accepting the fact that it is an elective medical intervention. The patient must be given options. We should highlight the risks and benefits, taking into consideration that malocclusion is not pathology, except for few cases. And we are, as a medical doctor, we are responsible for the information what we have. This is medically, ethically important. So if we are aware of the fact that this is a multifactorial disease, not only genetics, we as we start communicating with the patient that it is genetic, so this is breaching the medical ethics. So this is very, very important. And based on these kind of features, if we rethink the definition of the orthodontic specialty, of course, we work with appliances. We are the oldest specialty of dentistry. There is something that we can be proud of. And we are moving teeth and bones. That's fine. We use forces and appliances to change the dental situation and the skeletal situation. But the second chapter is, I think it is very important. So this was not present in the 1900s. So of course, this is new what took place all over the history of the orthodontic profession. So this is an elective medical treatment. As a medical doctors, we are responsible for the information. So we have to inform the patient about the multifactorial origin, and we have to present treatment alternatives, highlighting the risks of the treatment and the risk of the lack of the treatment. And certainly the risk of the treatment should not overcome the risk of the lack of the treatment, except for the situation when the patient, given all the information, makes this decision. Of course, in plastic surgery, it can happen all the time, but it should be based on information which is given to the patient. So we do not have right to threat the patient. The objective. So in the past, we made categories based on treatment appliance. So there is removal appliance orthodontics, fixed appliance orthodontics, visible, invisible. In the past, we differentiated pediatric orthodontics from adult orthodontics, but now we can differentiate orthodontic treatments based on the treatment objective. So now we can say that there are different type of orthodontic treatments. So in order to introduce different treatment categories based on the objective of the treatment, we have to make a small list of the potential objectives. So certainly we can improve smile and facial aesthetics, we can improve mastications, we can improve periodontal health, and we can prepare the dentition for restoration. But I propose to put improving the general health into the objective, because now we understand that we have a certain role in improving or worsening the general health, of course. So based on this, there are three major categories. So there is +1, the limited treatment for prosthodontics and periortho. But the three major categories are cosmetic treatments, full mouth restoration based on structural norms. So this is, I call the conventional contemporary orthodontics. So we measure norms, either it is hard tissue like bone and teeth and soft tissue, but we try to base our treatment on structural norms. But the third major category is health-centered and functional focused. So this is the new treatment category that I would like to introduce, which is based on how I can improve the health the most, and how can I avoid the effects, local and distant side effects the most. So this is the new treatment paradigm that I introduced. This is the functional health-centric orthodontic paradigm. that they try to achieve a nice smile, of course, but as much positive general health effect as possible and the least amount of side effect. So this is a full mouth orthodontic treatment with maximized positive effect on the general health and with minimized side effect locally and on a distance level. We can qualify functional or health center functional orthodontics by treatment directions, so airway centric, opening the maxilla as much as we can, moving the jaw forward, as the lower jaw as much as possible to open up the airway, uses the lightest forces possible to reduce the local side effects, the least obstructive appliance possible for improving the oral function, the tongue posture, even during the treatment, using all the highly, very rich proprioceptional reflexes, neural reflexes around the stomatognostic system. And we cannot achieve health improvement without collaborating with other specialists in our professions. And certainly this is a kind of a lifestyle change or kind of practice in which the patient has a certain role. So this is a paradigm shift that I have been suggesting for years, different forums, in order to understand that the arrival of the sleep and the importance of sleep, we can define now a new treatment category based on the treatment objectives. So formerly it was the angle area. Then by Dr. Sarver and Ackerman, we started to take pay more attention on the soft tissues around the 20 to 25, 6, 13. And then now the functional health centered paradigm arrives, and we should accept that this is a new possibility that we can provide to the patient. So these are the three major categories in the orthodontic specialty right now. And I think it is very important to place the fundamental foundation of a new approach. And the last part is how we should bring this kind of new type of orthodontic specialty into collaborating teamwork. And I just repeat again, so with the functional health-centric orthodontics, we want to achieve the most positive benefit possible and the least side effect. So how can we integrate in the collaborating teamwork? And in order to highlight this, I would like to get back. So as a Western medical doctor, we are trained as a specialist to look at the problems on a narrow focus. So we need to step back. And so I suggest the inside out instead of the inside out, the outside in approach. So I would like to ask us to step back a little and just look at what we do as a collective, collaborative team of different specialists on the craniofacial area, and look at how we can define what we do. So instead of inside out, so I would like to go outside in. So in order to define the name and the objective of the craniofacial collaborative work, I would like to start defining what health is. So health is a dynamic, balanced state. So this is not a status; it is just a process. And as a process, we are aiming for the balance. So this is very important. So we are talking about health as a balance. So we need to improve or increase the balance of the patient. So so I use this analogy in my conversations with patients and professionals that we look at the body as a battery, and we like to recharge it and fight with ongoing processes and increase the capacity of compensation. And when we talk about ongoing debates about tooth extraction and all the other interventions and their side effect, of course, it is not an isolated system. So many patients who are well with orthodontic treatment performed by tooth extraction. So they are doing great until the end of the life. So they don't develop any kind of side effects. And with the very same treatment, very same individual will develop side effects. So this is coming from a different places. So this is why all the studies that are trying to figure out the effectiveness of local treatment will not find the answer, because the ultimate consequence, the ultimate response from the body is defined by other features as well, the environment and the capacity of the patient's compensation. So this is why we need to look at the human body as a battery, so as a capacity of compensation. So this is compensation capacity. So this is how I look at, and there are many ideas and theories of compensation capacities in medicine. So so ultimately, we are working on the general health, general compensation of the body. So in order to make, like, for instance, an extraction therapy successful and non-symptomatic in the future, we need to support the patient's compensation. And we don't have to invent the wheel from the sketch, because definitely this is what functional medicine is doing. So we can approach functional medicine because this is the type of medicine that looks at the human body as a whole and does not treat the symptoms only. So so what is functional medicine? Functional medicine is an approach that tries to look at the human body's processes as a collective. So the sleep, the diet, the stress, the hormones, and everything from the general perspective, not symptomatic perspective, but the entire body, and looking at the environment, lifestyle, and everything. So so we don't have to approach the process again. In general, there are 4 pillars of functional medicine: the structural body balance, the psychosocial balance, nutrition and detox, and environment. Why I use this? Because we will be able to apply orthodontics and functional collaborative teamwork into this map, for instance. So what is the missing link? So what do we need more? And a definition of something that we call craniofacial functional teamwork. So so if we start collaborating, to the orthodontist, the functional orthodontist, functional dentist, we'll start collaborating with an ENT, with an orofacial functional therapist, the breathing specialist, the body worker. So ultimately, we will work on the health of the patient. So there is no local health; there is only global health, and this is the work that we ultimately work together with this kind of specialists. So in order to create this kind of missing link, we need to make a definition of craniofacial teamwork. And this is this. So collaborative functional medical teamwork is functional teamwork that ultimately supports the general health of the patient from the craniofacial perspective. So so this is quite simple, but we have to create this kind of missing link in order to put everything into the same map. So if we say functional medicine is aiming for the general health of the patient by looking at all the pillars of functional medicine and fixing those missing elements from the body balance perspective, from the psychosocial perspective, from the environmental perspective, from the detox and nutrition perspective. So this is the job into which we can integrate the craniofacial collaborative teamwork of dentists, OMTs, ENTs, speech therapists, and body workers that work on the cervical body as well. And definitely that type of orthodontic specialty that aims for health in general, the functional health and the functional orthodontist, is going to be part of this. So I think it is very important to put everything onto the same map, to understand that, yes, there is orthodontics categorization based on appliances, based on age, but now based on objectives as well. So and there is going to be a different type of orthodontics that not only works on the craniofacial structures, but it works on the functions, and the principle, the why, is going to be this: one health, one goal, one medicine. So in the future, not only the conventional structure-based orthodontic treatment will exist, not only the cosmetic orthodontics will thrive and go further with aligners, but there is going to be a new health center functional, sorry, the line has just dropped down into a different category, but this is the blue, the light blue arrow represents the health center functional orthodontic specialty. And I use this map, just finally, to put all these treatment modalities onto this map to develop teamworks. So on the body part, you can work with the body components, the muscle strength, the breathing, the craniofacial function, and of course, changing the structures can be part of it. But now we have the map with working with the functional neurology, with stress, with traumas, and with communities. So I use as a map for just yeah, so like a map to put team components, team specialists into one team to achieve the goals. So I think this is the time to change the focus from materialism to functionalism, and to deeply specialized medicine to integration. So now the pendulum changed this way, and then we are going further integration. And in order to be able to answer the whys and hows, why we do what we do, we have to step back, and the future of medicine is going to be more patient dependence, participatory, more functional, more preventive or proactive, and hopefully there is going to be affordable version of it, and certainly integrative. So this is why I find important to reestablish a new type of orthodontics and a new type of name for the collaborative teamwork, what we do on a craniofacial functional work, because it makes more sense for the patients, and it makes more sense for the practitioners, and it gives us a new perspective in the future. So thank you for your attention, and thank you for the invitation again.
Thank you for your contribution, for your approach. Is a new ortho approach and on functional medicine. Thank you so much, Dr. Herman. Thank you.
Thank you. Thank you.
Hello, can you hear me? Can everybody hear me?
Hello, good evening. Good afternoon, by the way.
Mr. Marian? Do we continue with the presentations?
Hello to everyone. Who's next?
I am waiting for a reply from Mr. Marian.
Okay.
Do we continue with the next presenter?
Yes.
Okay, thank you very much.
Next,
Greetings, Professor Marian.
Hello.
Hello.
Namaste.
Namaste.
Dr. Sivaraman.
Yes, Professor.
Thank you for your contribution. Dr. Sivaraman is as associate professor in the Department of Prosthodontics in Manipal College. He talked about zirconia versus titanium in oral implantology. Please.
Yes. Thank you, Professor Marian. I'm just starting with my presentation.
If you need help presenting your PowerPoint, we can assist.
Just a moment. I'm sharing my presentation now. Is it visible now for you?
Yes, we can see it. You can full screen it. So it's going to be on, yes.
Is it better now? Fine?
No, we can only see the minimized version.
It's okay. You can start the presentation.
Okay, greetings to one and all who are currently here for the presentation. And I would like to thank the organizing committee for giving me this opportunity to talk on the topic zirconium versus
wait a second.
titanium dental implants
on the full
and
screen.
evidence-based update. So this is quite a vast topic, and I would be giving an overview regarding the available data, the evidence, and how as clinicians we can interpret them for giving a better service to our patients.
Mr. Sivaraman, sorry for interrupting.
Yes.
We can see your presentation full screen. We can see the notes. If you can maximize the screen.
Just a moment.
There is in the right corner a presentation button next to the zoom bar. Yes, that's the one.
This one, right?
A little lower to the right. That's the one.
Yes. Is it better?
No.
It's not showing. Could you please go into Google Meet and present again using the full screen option, the entire screen?
Sure. Sure.
Thank you very much.
Yes. Just a moment.
Yes. When you present screen, you have Chrome tab, window, and entire screen. You need to select entire screen. Yes. Okay.
Yes. Is it better?
Let's see. Yes, it's much better. Yes, yes, it's
fine,
okay.
Fine. Okay.
Thank you very much.
Sorry for the inconvenience.
No worries. Thank you.
So, yeah. So I would be talking on this topic, zirconium versus titanium, dental implants, and evidence-based update. So we already know that titanium is an established implant material, and it has been used for treatment of cases with wide variety. Like even if it's a single missing teeth, or it's a couple of missing teeth, or it's an extensive rehabilitation, we do use titanium, and we know it's quite predictable and quite safe to use with good survival and success rates reported. So now we are coming across zirconium zirconia rather, as an emerging alternative to titanium. So what we need to find is this a material with comparable mechanical properties? Does it have good biological properties? Does it have good aesthetics? How does it perform in compared to titanium? Is it really going to take over titanium in the coming years and become the mainstay of dentistry? So we will be exploring all these aspects in the presentation. So first and foremost, we need to understand that in the periodic table, the titanium and the zirconium are located quite close to each other. And as a result, they will share similar properties. And they both are transition metals. So when we talk about titanium implants, they're basically fabricated of titanium alloys or commercially pure titanium. So when I use the term alloy, it means we are combining different metals. So when in an alloy, we will see metallic bonds between the elements, and there will be free electrons, and as a result, greater electronic conductivity. On the other hand, when I talk about zirconium implants, they're basically fabricated of a zirconium dioxide. So it's a combination of zirconium with oxygen. So we will be seeing an ionic bond and properties which are not conforming with that of an alloy. So what we need to understand and reinforce is zirconium metal is not the same as zirconium dioxide, also commonly known as zirconia. So we already understood that zirconium dioxide or ceramic oxide is not similar to a metallic alloy. For instance, we know that titanium and zirconium are combined to form a rock solid, which is a metal alloy. But we find zirconium dioxide is not a metallic alloy. So the applications and the physical properties will vary. The other important aspect is there are a lot of discussions regarding how zirconia is gradually being increasingly used by clinicians. However, when I came across this survey, it's based in the US dental implants market. So currently, the global dental implants market is valued at around $4.9 billion. And if I look at the US dental implants market, we see a growth projection chart, and it projects a 10.2 compound annual growth rate from 2024 to 2030. Of interest, however, is that even though the amount of implants being used is forecasted to increase significantly, titanium's implants do remain the mainstay and are not being increasingly replaced by zirconium. Even though the margin of zirconium has increased, it's not going to replace titanium in the near future. So initially, when we were using ceramic implants in dentistry, we were mainly using alumina, but they were removed due to poor mechanical properties. So zirconia in its pure crystal phase has three phases. It has monoclinic, tetragonal, and cubic. So the monoclinic phase exists up to a temperature of around 1170 degrees Celsius. The tetragonal existing to a temperature of around 2300 degrees Celsius, and cubic existing above the temperature of 2300 degrees Celsius. Now, when there is a transformation from the tetragonal to the monoclinic phase upon cooling, there is a volume expansion what is seen, and there is a propagation of crack, which can result in adverse mechanical properties of zirconia. So to avoid that, there was a series of stabilizing oxides which were added, common amongst which is yttrium oxide. So that resulted in a martensitic-like transformation toughening for the material, and is the main reason why the mechanical properties of zirconia are improved compared to its predecessor alumina. However, we also need to understand that under certain manufacturing conditions, especially under exposure to moisture and stress, there is a transformation of this tetragonal phase to monoclinic phase from outside to inside. And this is in form of a crack propagation, which will result in reduction of the strength, toughness, and density of the material. So this will result in adverse consequences for the properties of the material, which were supposed to be enhanced in the first place. So this is also known as aging. So to improve the durability and stability, alumina had been added later, and this is known as tetragonal zirconia polycrystal with alumina. Now, in vitro studies have found this evidence for aging, but they are found to be within the clinical acceptable limits. However, the concern for us is there are various manufacturers for zirconia, and most of them do not have a clear R&D. What I mean is the clear process of manufacturing and the conditions. So if you are using an implant from an unverified manufacturer, who does not provide a data, you can have troubles later with the implant during clinical use. So when we talk about the mechanical properties, the modulus of elasticity is very frequently spoken about. So we basically desire an implant material which will have an elastic modulus closer to that of bone, because we want the stresses to be distributed uniformly and less disturbance at the bone implant interface. So when we look at the values for the titanium alloy, which is frequently used, its elastic modulus is 110 gigapascal, which is higher than human bone at 10 to 30 gigapascals. But when you look at the values of zirconia implant, which is yttrium stabilized, it is around 210 gigapascal. So there is a considerable difference. Now, when we have an elastic modulus which is closer to that of bone, we do not see any stress accumulation within the implant. When we take an implant material which has a greater elastic modulus and greater difference compared to that of bone, you will have a stress shielding effect which is seen, and as a result, the implant material will be prone to fracture, and it will also result in a altered bone remodeling process. So if we analyze this data objectively, we see that the titanium alloy has much favorable result over a long term due to this major difference. Also, when we talk about an implant, we want it to be biofunctional. We do consider the properties like tensile strength, compressive strength, fracture toughness, yield strength, fatigue strength, and ductility. These are all important for the biomechanical component. And titanium alloys do fare better than zirconia in this aspect. But why are we concerned about the mechanical properties in the first hand? That is because the mechanical properties influence the design of the implants or the treatment protocol. And we would be looking at how. For instance, we mostly practice two-piece implants. And in two-piece implants, the abutment is tightened onto the implant body. And that is possible because of the elastic deformation which is happening within the screwing material as well as the implant body substrate. So if it's a titanium two-piece implant, both the screwing material and the implant body substrate are of the same material. However, when we are using a zirconium implant, if we use it in a two-piece manner, we know that zirconia has a high elastic modulus. So there will be a greater resistance to such elastic deformation. On the other hand, its fracture toughness values are relatively low, so it can fracture in thin cross sections. So that is the reason the zirconia implants were initially introduced in one-piece form to avoid this weak implant abutment interface. Even subsequent two-piece zirconia implants prefer this interface to be of chemical bonded rather than having internal threads for micromechanical retention. So this is one aspect how a mechanical property will influence the design of an implant. What else? Now, when we place an implant, we know or prefer that we place it in a position whereby there is no early loading of the implant during the healing phase because it can impair osseointegration or the bone implant contact. However, when we place in one-piece zirconia implant, there is a greater probability of early loading during healing phase and compromise osseointegration. Also, when we talk about a two-piece implant, we know that there is a hollow slot in the implant body. Now, when there is a stronger metal like titanium, you can make it in thin cross sections. Or if the bone availability is less and you cannot consider surgical options, there are narrow diameter implants. However, when you consider zirconia, studies have actually recommended against using narrow diameter implants. And since we know that the mechanical property is not as good as titanium, we cannot take the risk due to adverse results. So moving on from mechanical properties, the next important property is optical and aesthetic properties of titanium and zirconia. So zirconia is highly perceived as an aesthetic material amongst the clinicians. And in this case, like we can see, you have a gray hue, resulting in perceived poor aesthetics in patients, especially with a thin tissue biotype and high smile line. So we need to actually contemplate whether is it the titanium which is lacking aesthetic, or in this case, is it the lack of appropriate treatment planning? Did the clinician actually consider the tissue biotype? Did he or she consider the smile line? Did he or she contemplate any adjunctive hard or soft tissue grafting procedure? This kind of aesthetic complications can also be seen in cases where immediate extraction and implantation has been done, whereby where technical expertise is very important. So we do know that as clinicians that zirconia implants do look aesthetic, but what is the perception of the patient? So here is a publication which was done by Gallert et al., where in around 2018, in which they conducted a study which was conducted in Basel as well as Munich, and around 30% of the patients in Basel preferred ceramic implants, with a high number of around 53% preferring ceramic implants in Munich. And the preference towards ceramic implants were mainly motivated from the perspective of aesthetics. So in this case, the patients also tend to incline towards ceramic implants, thinking they are going to get an aesthetic treatment. So first we had a look at the mechanical properties, whereby the titanium was felt to be superior. When we looked at the aesthetic properties, zirconia had a greater aesthetic result. So moving on to the next important part, which is biocompatibility. Now, when we talk about biocompatibility, it's about the chemical reactivity of the material. Now, titanium element itself is extremely reactive, and it forms a surface layer of titanium dioxide. Now, this titanium dioxide, even if it's scratched and removed, tends to repair itself, which results in an kind of an impression that it's very passive in nature. And this is a reason why it is supposed to have a high corrosion resistance, and there is an apparent lack of safety issues in the human body. But the important question here is corrosion is a good corrosion resistance responsible for the biocompatibility with surrounding hard tissues, or there are additional factors? What I mean here is, if a material is very exhibits a very good corrosion resistance, does it mean that it's very biocompatible with the surrounding tissues? The answer is no, because there is gold, which is an extremely corrosion resistant metal, but it's found to be inferior in tissue compatibility. Studies have also shown that in order to increase the corrosion resistance of titanium, when platinum was electrically plated onto it, it did improve the corrosion resistance, but it reduced the bone formation. So moving on from the titanium oxide, we know that there's a layer of titanium oxide formed over the surface of titanium. Now, it does react with the moisture present in the air to form hydroxyl groups, which will subsequently form electric charges upon dissociating in aqueous solution, like body fluids. So depending on the pH of the surrounding solution, these charges are balanced between positive and negative at a certain pH, defined as the point of zero charge. So basically, the point of zero charge is a gauge of acidic or basic property of a surface oxide and will vary with the material. So when we look at the PZC value for rutile and anastase, which are crystalline phases of titanium, we see that it exhibits almost a neutral property. There is also a large concentration of surface hydroxyl group seen, which on immersion in aqueous solution increase in concentration and promotes the absorption of proteins such as integrin and cytokines, which are further important for the compatibility with surrounding tissues, especially bone. So a seemingly passive surface oxide layer actually keeps on undergoing changes in which there is a partial dissolution as well as reprecipitation from a microscopic point of view. So there is a great influence of the environment on the composition of the surface oxide film. Now, when we consider the commercially pure titanium and titanium alloys, there has been deposition of calcium and phosphorus at the interface of such materials with the bone, and even deposition of sulfides and sulfides in cell culture media. So there is a good biocompatibility seen in case of titanium. So how does zirconium dioxide fare in comparison to titanium? Like titanium, they do form hydroxyl groups on the surface upon reacting with moisture in the air and dissociates in aqueous solutions. However, unlike titanium, the PZC for zirconium dioxide is 3.6 to 4.2, implying that the surface is relatively alkaline in the human body. Importantly, lesser number of hydroxyl and phosphate groups were deposited on the surface of the yttrium stabilized tetragonal zirconium, while the deposition of calcium ions could not be confirmed. So this is a very important aspect which we need to consider when we move on to the other aspects in form of evidence later in this presentation. Now, when we speak about biocompatibility, we also should be discussing about allergy or hypersensitivity. Now, when you go across the articles, you will find that titanium allergy or hypersensitivity is raised as an issue for possibly introducing zirconia as a viable alternative. So let's go through the incidences to assess whether this is really a widespread and serious issue, or is it just being is just a fear. So when we look at the titanium levels in our body, you approximately have 50 ppm exposure already, because the titanium is routinely used in fashion products or even in sportswear, especially since it tends to impart a white color. When you place a titanium implant in a patient, that 50 ppm might raise to 100 to 300 ppm. And apart from dental implants, titanium have a various range of applications which are shown in the figure here. Now, there are several published reports which have raised the possibility that this may cause a systemic delayed hypersensitivity or localized contact dermatitis. Now, when we speak about hypersensitivity reactions, they are classified by Gel and Combe as 4 types, where the first 3 types are antibody mediated, and the type 4 is delayed hypersensitivity. So in delayed hypersensitivity, we do see inflammatory reaction, which will be peaking within 24 to 72 hours. And the contact dermatitis is the localized form of delayed hypersensitivity. So much of this evidence for the so-called titanium sensitivity is coming from orthopedic research and not dental literature. We also need to understand that the oral mucosa has a different set of immunological properties compared to skin. For example, it is less permeable and is coated by salivary glycoproteins. For instance, the studies say that at least 5 to 12 times the concentration of allergen has to be present for eliciting an allergic response for titanium. However, we need to note that there are a few documented cases in association with dental implants. But common to these cases are the absence of past history of contact hypersensitivity to metals. One of the good extensive studies which I came across in the literature was performed by Silesia et al. In 2008. So in this study, around 1,500 patients were enrolled, in whom implants had been placed between 2002 to 2004. And of these 1,500 patients, 35 patients were selected. In these 35 patients, there were around 16 patients in whom unexplained titanium failure had happened. And the remaining had a previous history of allergy to other metals, excluding titanium. So these formed the group of 35 patients, and the other were a control of 35 patients. So in the second phase of the study, these 35 patients and 35 controls were subjected to cutaneous and epicutaneous test. So what were the results? Titanium allergy could be detected only in 0.6% of the subjects. So it's an extremely low prevalence. There are studies which have hypothesized that the trace elements of nickel, chromium, and palladium, which are present in these titanium alloys, might in fact be responsible for the documented titanium sensitivity, hypersensitivity, or allergy. And it's not per se the titanium as such. Also, there are diagnostic tests which are frequently discussed about, including patch test, ECT, MELISA, or LTT. So there are studies which have concluded that these have shown inconsistent results in terms of reliability and validity. So this is a recent publication in 2022, the German S3 guideline on titanium hypersensitivity in implant dentistry. So the authors concluded that for reasonable decision making, a patient's clinical symptoms should be regarded as a leading parameter, which are usually expressed by local inflammatory reaction. Importantly, allergy tests such as the epicutaneous test or the lymphocyte transformation test are not helpful in titanium tolerance assessments. In case there is a localized inflammatory response, the implant has to be removed, and you can consider a dental ceramic implant as an therapeutic alternative. So this is regarding the titanium hypersensitivity, an extremely low prevalence, and it's not easy to diagnose in a patient either. So we went through the mechanical properties, we considered the aesthetic, we looked at the biocompatibility. Now the biocompatibility obviously has a kind of effect when we are going through the bone formation, bonding, osseointegration in zirconium versus titanium implants. So we know that osseointegration is defined as the apparent direct attachment or connection of osseous tissue to an inert alloplastic material without intervening fibrous connective tissue. Now, when we speak about bone formation or this bonding or osseointegration, what we need to keep in mind is that it will be majorly influenced by the chemical nature of the material concerned. So we know that zirconium and titanium are similarly placed in the periodic table, but there will be certain properties which will vary, like in form of oxidation rates, the water interactions, crystalline structures, these will vary. And we need to assess whether these properties are the one which are influencing the outcome, what we see in the studies. So the outcome, there are multiple studies which have documented various aspects of osseointegration pertaining to titanium. So I'll be going briefly about this zirconia aspect here. So one of the early studies was done by Akagawa et al. In 1993. So they had conducted a study whereby there was a clinical and histological evaluation of partially stabilized zirconia endosseous implants under loaded and unloaded condition in 4 beagle dogs. So what they found here is there was an appropriate bone implant contact happening in both the cases. However, there was a bone loss in the implants which were loaded early. And that's why the recommendation came that it should not be loaded early in case of one-piece zirconia implants. Otherwise, it can impair the osseointegration rate. So this study could basically establish that there is a reasonably good level of bone implant contact. So the next step was to find whether this could be sustained over a greater period of time. So Akagawa et al. Again in 1998 conducted a study which was comparing this situation between freestanding and the tooth connected, partially stabilized zirconia implant. So what did they conclude? They concluded that one-piece zirconia implants in one-stage procedure could achieve long-term bone implant contact and osseointegration. And they recommended that these one-piece zirconia implants be put for clinical trials. Now, much later, we see Gallet et al. Conducting a study in around 2007, in which biomechanical and histomorphometric comparisons were performed between zirconia implants with varying surface textures and a titanium implant in the maxilla of a miniature pig. So basically, a titanium SLA surface implant was taken, and they were compared to 2 zirconia implant specimens. One set of zirconia implants had a machined smooth surface, and the other set of zirconia implant were made rough by sandblasting. On initial examination, it was found that the SLA titanium surface had a rougher surface, and now the pigs were subjected to extraction of teeth in the maxilla, 2 teeth in fact, and then they were replaced with these set of implants with the titanium SLA serving as a reference. After a healing period, the implant, just a minor correction. Initially, the extractions were done, a healing period was allowed, and then the implants were placed. So we had a healing period of around 4 and 8 weeks, subsequent to which there was a reverse talk test done, and the values compared. A set of samples were also taken for histomorphometric comparison between zirconia implants and the titanium SLA surface. So what did we see? The surface analysis revealed the highest surface roughness for the SLA implant, followed by rough zirconium dioxide implant, and the least values were found for this machined or smooth zirconium oxide implant. The turned zirconium dioxide implant also showed statistically significant lower removal torque values than the other 2 implants after 8 and 12 weeks. So to conclude, compared to the machined or smooth zirconium dioxide implant, the rough zirconia implant or the zirconium dioxide implant achieved a higher stability in bone. So this is one of the earlier studies where we see that a roughened zirconia implant is giving a better stability, a better bone implant contact, and better osseointegration compared to a smooth or machined zirconium dioxide surface. In a way, it parallels this journey of titanium as well. When titanium was introduced, that also was kind of machined and smooth. Subsequently, we had different titanium implants being introduced with different features. So this was a meta-analysis of the preclinical studies which were conducted in 2023 by Ramosu et al. So this was basically all the preclinical studies till then were included, and there was an evaluation of the performance of the zirconia implant in comparison to titanium. So what did these authors find? They found that within the limitations, the zirconia implants had a similar level of osseointegration compared to titanium implants. So according to them, there was no difference between the level of osseointegration or bone implant contact observed for both the types. However, there was an important study limitation, and that is always something which we need to look out when we are looking at the results of any study. There was a lack of standardization in terms of period, as well as the surface of the implants which were assessed. Many of the studies did not mention as to whether they were using a roughened surface or a smooth surface, or even if the roughening was done to what level. So there was an ambiguity in that case. So that prevents an appropriate comparison of osseointegration and appropriate result, what could be told. So I'll just telling you about one more study here. And this was again done by Rowling et al. In 2019, whereby zirconia was compared to titanium dental implants in preclinical studies. It was again a systematic review and meta-analysis in 2019. So what did these authors conclude? They found that zirconia tended to demonstrate lower bone implant contact values and reduced removal torque values compared to titanium. However, they mentioned that there is a serious limitation to the observation what they have given. There are various criteria which tend to affect the overall assessment in form of implant loading protocol, the length of the follow-up, loading period, and the animal type. For instance, in this, when they compiled the studies, there were different animal models which had been used to compare zirconia and titanium. So it varied in form of rats, pigs, you had dogs, sheep. So for instance, when they compared the performance of zirconia to titanium in pigs, there was a statistically significant difference in terms of performance. But when they saw or correlated the results in a rabbit model, they found that both performed similarly. Normally, when we combine different animal models, it's always a source of controversy. But the authors did go ahead and combine these different animal models to come up with their final assessment that zirconia does demonstrate lower bone implant contact values and reduced removal torque values compared to titanium. The authors also felt that with improved manufacturing process and the creation of micro rough surface topographies on zirconia implants, there is an improved osseointegrative capacity and survival rate. So the previous or older versions of the zirconias which were introduced and used were not as good as the ones which are commercially available now. Currently, when you look at the zirconium implant surfaces, they are subjected to acid etching or sandblasting, and they have demonstrated better bone implant contact and better osseointegrative capacity. So after the hard tissue integration, it will be kind of incomplete if we do not look at the soft tissue aspects as well. So when we look at dentogingival tissues, we know that it's very important. Their presence is quite important for preventing bacterial ingress and infection. So when we look at the peri-implant tissues, they also play a similar role. If there is a poor addition of soft tissue to the implant or implant abutment, that can potentially progress to perimucositis and then to peri-implantitis. So that's why we should always consider taking care of the soft tissues around the implants as well. And apart from the health, it also plays an important role in aesthetics. It's about the type of margin which is given, the position of the papilla, the health of the soft tissues. They all play an important role along with the restoration to give the final aesthetics. So how does zirconia and titanium compare in this aspect? What is the nature of soft tissue attachment here? So studies have established that the nature of soft tissue attachment are quite similar in both zirconium and titanium. The collagen fibers were also observed to be oriented parallel to the implant surface with similar probing depths for titanium and zirconium implants. Now, those were the similarities, but there are a few differences as well. There was a significantly higher content of collagen and a shorter length of the sulcular epithelium around zirconia implant. So around 0.76 mm for zirconia compared to 1.4 millimeter for titanium. Also, the biological width was found to be more 2.85 millimeter for zirconia implant compared to 2.3 millimeter for titanium implants. So the longer junctional epithelium, in addition to the high density of collagen fibers, are said to provide a better soft tissue integration and better resistance to any bacterial ingression, resulting in low chances of or lower chances of peri-implantitis. So what are the factors or properties which contributes towards this inhibition of bacterial adhesion and plaque buildup on zirconia implants? So they include a range of factors which can be divided into implant surface properties and host response. So the relative bioinertness along with reduced surface energy is supposed to be a major property of the implant surface in zirconia, which inhibits the buildup of bacterial adhesion and plaque buildup. But importantly, we need to look at the host response as well. The studies have documented a low inflammatory response, which is attributed to release of anti-inflammatory cytokines in increased quantity compared to titanium implants. So you have a situation whereby there is less tendency to accumulate plaque, less tendency for bacterial adhesion, ingression, progress, and also a less inflammatory response on part of the host or the body. So this should logically lead to the conclusion that you see less peri-implantitis or less prevalence of peri-implantitis compared to titanium implants. And that would definitely be in agreement with what has been observed in the preclinical studies or in vitro studies as well. However, there are certain differences or certain points which we need to consider here again. When we speak about peri-implantitis in the literature, we see a lack of consensus and agreement on the definition, and that has resulted in varying prevalence rates being published in the literature. In fact, there are contradictory results regarding incidence of peri-implantitis in zirconium and titanium implants. Like I mentioned, in the preclinical studies, there is evidence to say that there is less incidence of peri-implantitis in relation to zirconia. But when we look at the literature, even clinical aspects, we see contradictory results. The other aspect is for increasing the bone implant contact and increasing the osseointegration, we have increased the roughness of the implants. However, when there is gingival or the recession of the tissues around the implant and exposure of such threads, these threads tend to accumulate plaque, buildup of bacteria, and then they tend to encourage the formation of or lead to perimucositis and peri-implantitis. Now, this roughness is generally seen to be more in titanium compared to zirconia. Now, what should be our conclusion from this now, since there are so much contradictions regarding the results? There has been a study by Cottinelli et al. In which they mentioned that patient compliance, including plaque control, and regular dental follow-up appointments may be more important in maintaining oral hygiene and preventing peri-implantitis, regardless of whether the patient has been treated with titanium implants or zirconia implants. So that should be the takeaway for the clinicians. Just because you place a zirconia implants, you cannot rest thinking that, okay, this is less prone for peri-implantitis, considering all the factors which were mentioned before. We need to have a regular follow-up, and the patient needs to be educated well enough to ensure oral compliance. So now this is the important part of the presentation. What is the evidence and what are the recommendations based on recent studies? The previous part of the presentation gave you an idea about the essential differences between these materials and some evidence based on preclinical or in vitro studies. So now this set of evidence has been taken from a study done by Duan et al. And published in 2023. So the first aspect is about the success and survival rate. Now, when we speak about a success rate over a 5-year period, we expect a greater than 85% for the maxillary implants and a greater than 95% for the mandibular implants. Now, what has been, the authors have stated in this study is that the success rate of zirconia implants are significantly lower than that of titanium implants. The survival rates were also low, but they were not statistically significant. Now, what were the reasons? There were technical complications seen in form of occlusal chipping, and these were attributed to variations in manufacturing methodology. So, according to the authors, the manufacturers may be the main contributor to the extreme heterogeneity in survival and success rates among the randomized clinical trials or cohorts, and that brings us to the original point, the point which I mentioned before, that when you are using an implant, whether it's in this case zirconia, we need to ensure that the manufacturer has an established R&D process on the methodology and has data on the performance of the implant. Now, this study also observed that the zirconia implants had higher failures or prosthetic failures, especially in the posterior region. So they recommended that the zirconia implants not be used in the molar region. Now, what is this other evidence? There was a marginal bone loss comparison between zirconia and titanium implants, and it revealed a favorable result for titanium. Now, this is a bit incomplete because they stated that overall titanium and zirconia performed similar in terms of marginal bone loss, but when they included a study done by Ostman et al. In 2014, including overdentures, the titanium implants the zirconia implants did not fare well. Now, what could be the reason? The reason is that the occlusal forces which a single crown might be subjected to, or that implant under a single crown might be subjected to, is much less compared to an implant which is subjected to forces under an overdenture. So the recommendation of the authors was that the overdenture on zirconium implants have additional risk but no benefits, and they should not be recommended in any clinical setting. In any cases, only in cases where there is a documented titanium allergy should the clinician go ahead with a zirconium implant to receive an overdenture. The next evidence is pertaining to periodontal probing depth, and here they found comparable results under normal mucositis mucosal conditions, and significant difference under mucositis conditions. So if it's a normal mucosa, the periodontal probing depths were quite similar, not statistically significant. However, if it's a mucosa exhibiting mucositis, the periodontal probing depth showed variation. So what is the recommendation of the author? They said that the zirconium and titanium implants can both achieve healthy and stable soft tissues, but zirconium implants may compare favorably with the mucogingival findings reported on patients exhibiting mucositis conditions. Then, as we discussed before, there were contradictory results regarding peri-implantitis for zirconia and titanium. So the recommendations of the authors were that the patients need to have a good oral compliance and a supportive periodontal therapy program to avoid bacterial accumulation and implant loss, regardless of the fact that they were treated with titanium or zirconium. Now, the evidence and recommendations pertaining to the pink aesthetic score. Now, initially, I mentioned that the clinicians and the patients have a view that being a ceramic material, zirconia is a very aesthetic material. So this also assesses the pink aesthetic score of both the implants, or both the set of implants, titanium and zirconium, and both of them were found to be acceptable. So the authors recommended that in cases with a thin gingival biotype, especially in the aesthetic zone, zirconia implants could be considered to be a better choice. So it means or implies that there is nothing wrong with titanium as such in terms of aesthetics. Better treatment planning is required. A meticulous planning is in fact recommended, and factors such as smile line, gingival biotype have to be evaluated. Any augmentation procedures in terms of hard or soft tissue should be considered, and they should not be ignored. Now, a few set of recommendations are based on an evidence from another study, which was published in 2024. Now, there is a greater tendency for the clinicians to use a zirconium abutment along with a titanium implant in the anterior region. They feel that it will impart or combine the advantages of zirconium with titanium. It will give a better set of aesthetics. But there is evidence to show that zirconia abutments associated with titanium implants showed significantly higher values of wear at the connection interface. Now, what is the reason for that? We know that there is a difference in modulus of elasticity between these two set of materials. So we have titanium with a lower modulus of elasticity and zirconia with a higher modulus of elasticity. So even though the titanium can undergo an elastic deformation, the zirconia implant will resist it, and there might be a greater wear at the interface between these two materials. It will not be similar to how a titanium abutment will be placed on a titanium implant. So The other finding in this study was that this wear will vary depending on the geometry of the connection. If you have an internal connection implant, the wear will be more because the external connection will ensure a greater surface area over which the stress will be distributed. So the recommendations of the authors are that in case you plan to use an internal connection treatment, and you're providing a two-piece zirconia abutment with a titanium abutment or tie base, will be better. It will ensure a better adaptation and preservation at the implant connection surface. So go ahead with a zirconia abutment with a tie base to ensure the less wear of the interface. The other important evidence is that milled zirconia abutments showed 3 to 7 times greater misfit than milled titanium abutments. And what is the reason? Subsequent to milling, it's subjected to sintering, and this sintering process results in shrinkage up to 25%. So the recommendation is that the necessary dimensional increase of the milled structure should be done during the planning so that that can account for the shrinkage post sintering. So these two set of points are equally important when we consider about integrating the zirconia abutment with an existing titanium implant. Now, towards the end of my presentation, I would be going through the other set of evidence which was presented at the 7th ITI Annual Conference in Lisbon 2023. So there were a set of consensus statements and recommendations which were given. So as I have mentioned before, there are a set of zirconia implants which are no longer available or commercially being used. And there are newer set of zirconia implants which have been introduced into the market and are commercially available still. So there were a set of 6 consensus statements. And the first important statement, the first consensus statement mentioned that the available data, there can only be a set of conclusions drawn regarding to one-piece zirconia implant. According to the people or the researchers and the clinicians who sat down for this consensus statements, they felt that the data is available for two-piece zirconia implants is insufficient. The subsequent statements mentioned that the new commercially available zirconia implants have a better survival rate than the ones which are no longer in market and are at par with the titanium implants. Other equally important thing is that the marginal bone loss which was seen with the new commercially available zirconia implants was just 0.67 millimeter, which is much lesser than around 3 millimeter values which were observed previously. The fracture rates for the one-piece zirconium implants were also as less as 0.2% with the new commercially available zirconia implants. So these were the important consensus statements which one can go through. And what were the recommendation? The recommendations of the ITI body was that the one-piece zirconia implants for single crowns and 3-unit implant fixed dental processes only. So they did not recommend any versatile or diverse applications of zirconia. They have they have recommended that the two-piece commercially available zirconia implants be used with caution since there is insufficient supporting data, and the one-piece zirconia implants be used only for single crowns and 3-unit implant fixed dental processes. So this shows that the body is quite cautious when it examines the available or existing evidence, and we still cannot say that zirconia is as versatile or dependable as titanium, which is an existing gold standard for any implant material in the market currently. When we speak about a single piece implant, they also recommended that the difficulties relating to submucosal prosthodontic margins, like removal of cement excess, be considered so that the health of the peri-implant tissues are not compromised and they can be maintained. So to conclude, zirconia was proposed as an alternative to address the perceived drawbacks with titanium implants. However, on going through the existing literature, the data, we see no clear superiority in relation to mechanical properties or osseointegration. We do not see the rate of allergenicity or hypersensitivity to be alarming in case of titanium implants, which warrants action. There were definitely an aesthetic benefit, which is there with zirconia implants or abutments. Now, clinicians who are using zirconia abutments with tie base will have a better survival rate. I think I need to rephrase it. When you use a zirconium abutment with a titanium base, that will show better survival rate, since there is less wear at the junction or the interface. So zirconium implants can be established as a viable alternative only after future studies with greater methodological rigor, interventions, and longer follow-up time determine the safety, indications, and drawbacks for its use. So thank you one and all for your patience and listening to this presentation.
Thank you for your contribution, Dr. Sivaraman, for your very interesting lecture and for your contribution in Elsevier book project. Thank you.
Thank you,
Namaste.
Professor. Thank you. Namaste.
Next speaker is Professor Stanislav Blum from St. Petersburg. He is present. Topic: facial asymmetry, aging, and posture changes in neuromuscular concept. Please, Stanislav.
Okay, wait a minute. Wait a minute. I just start my presentation. And yep. Wait a minute. Yeah, everything okay? But wait a minute.
Yes, we can see the presentation.
Yep, but
You cannot interact with it. You cannot move it. You cannot
Yep.
move the slides.
I changed the slide now.
Okay. Yes, it's working.
Yeah, and you see the mouse point.
Yes, we can see the mouse. It's no
Super.
problem.
Okay. So I start. Yeah, my name is Blum Stanislav. I'm orthodontist from St. Petersburg. I have two clinic. First clinic is a dental clinic, Center of Functional Orthodontics and Prosthetics. And second one, it's a general medical clinic, functional clinic, Center of Functional and Anti-Age Medicine. So I want to start with two quotes. First quote, it's a quote of Peter Dawson. You can help people unless you can masterfully diagnose, because people primarily respond to only pain. It's very important because a lot of people have a different functional disturbance of craniomandibular system, but don't know about it. Yeah, because they don't feel any pain. So the second quote, it's Bernard Jenkelson, the father of neuromuscular dentistry. If you can measure it, it's a fact. If you can't measure it, it's an opinion. It's a very important point because, in my opinion, the modern medicine have a difference between the medicine of our past. It's in a diagnostics. Yeah, because it's very, very important. Now we live in era of evidence-based medicine. We need some record to measure it. Yeah, if you measure it, you control it. It's very important. So I have a two functional specialization. First, it's functional orthodontics or functional jaw orthopedics or dentofacial orthopedics. The next one, it's neuromuscular dentistry. Really, it's a very, very similar approach, but in neuromuscular dentistry, we use TENS, for example, to change mandible position. In functional orthodontics, I can use different appliance. Yeah. Okay. I want to start with this picture. It's a very old picture of Professor Wilma Simonas, functional octahedron. So it's a topic on which we can affect working in functional approach. We can change, and it's our main goal. We can change mandible position. Of course, with mandible, we change tongue position. Of course, we change both TMJ position because it's a part of mandible. So we can't separate these 3 points. So of course, if we change mandible and tongue position, we influence on neck. It's very important. In all patients, I can't change mandible position without neck. So if I'm aligned mandible, I'm aligned neck in similar way. So if I change mandible position, I change in patient vertical dimension of occlusion. So I change facial symmetry, facial relationship, the thirds. So we change facial aesthetics. If we influence effect on neck, we're working with all posture. Of course, we change inframandibular region. It's very important if we're talking about face aging and facial aesthetics. Of course, we influence on airway. It's old picture. I think in a modern, the same. The old topics is the same, but maybe we a little bit rotate this picture and place on the top maybe airway. I think. Okay. So that's why our main clinical direction, of course, it's craniomandibular disorders, posture problem, airway and sleep medicine, and mostly airway and sleep dentistry. But the second clinic is general medicine. I have a somnologist in my staff. And at the end, anti-aging dentistry. What is anti-aging dentistry? It's a part of neuromuscular dentistry, or it's a part of functional orthodontics or functional dentistry. When we try to decrease the age-related functional disturbance in craniomandibular region. Okay, for example, very, very simple case. Before and after, a little bit we changed mandible position, made some build-ups with composite, not so much changes. A little bit better midline. Yeah, we align vertical dimension of occlusion on left and right side. And look how we change facial aesthetics before and after. We dramatically change all lower thirds, the symmetry of lower lip, yes, the mandible line, double chin. Look, the line in the angle of a mouse. In Russia, we called it marionette line. I don't know the original name. Okay. So we change mandible position, we change vertical dimension of occlusion, symmetry, and we can see dramatically changes on the facial aesthetics. Okay, why we now can talk about anti-aging dentistry? If you look on PubMed and print aging face on a search line, you can see the dramatically a rise of a number of publications about this topic. Every year, we have more and more articles, investigation about this problem. I'm not pioneer, of course. We have pioneers. For example, it's a book of anti-aging medical therapist, and we have a chapter anti-aging dentistry and overview to how dentistry relates to longevity and quality of life. Ira Shapira, very famous neuromuscular specialist. Now we understand how our face change in a soft skin per years. Now we have a lot of publication about it. It's not new information. That's why we use a face scanner in my practice, because you know it's very complex to compare two photographs take it in a different time, because in all photographs you have a problem with a deformation, image deformation. Yes, because you have a different type of lens on your photo, and it's the quality of photo, and it's very depend from size between lens and object, light quality, and a lot of different things. Okay, on face scanner, I have a really 3D information. Yeah, it's image. It's not image, it's object. And I can compare these two objects in a different time period. So we need to prevent age-related changes in occlusion, temporomandibular joint, posture, muscle, sleep, and of course central nervous system, because our muscles ruled by central nervous system, our muscles give to us mandible position, TMJ position, tooth relationship, so it's occlusion, and of course our muscles made our posture. So central nervous system, it's very important. So, of course, you know everything about tooth aging. It's a tradition. Per years, we lost tooth anatomy, the cusps on posterior teeth, and not only on posterior, yeah, on canine. So it's very easy, but you can see that per age, we find totally new occlusal anatomy. Not only, and I'm not talking about only teeth. I talk about Monson sphere and curve of Spee. It became deeper, and curve of Wilson. It became totally different. So it's very important when we start modeling the new teeth. Yeah, but now my topic about facial aesthetics, posture, and facial aging. Okay, you know, it's very famous comic actor. It's Ben Stiller. I tried to align to picture by intra-pupillar line, so between eyes, and you can see, of course, the muscle disorders, the facial asymmetry, we can see in young years. Yeah, you can see that chin slightly moved on the left, but per years the asymmetry became dramatically worse. On smile, you can see the angulation of upper arch, upper dental arch. Yeah, and in osteopathic books, it's called cranial scoliosis, side bending rotation. It's type of cranium deformation. Of course, in my opinion, not only in my opinion, the muscle disorders, so asymmetrically muscle function, its main problem, main goal of this, main reason of this asymmetry, main reason of this problem. You can find a lot of this information, for example, in this book. It's new book of Massimo Aita, New Posturology, and you can find information not only about posture, but about facial asymmetry. Different type of deformation, and how dentamuscular orthotics can work. Of course, the mandible moved on side of minimal vertical dimension of occlusion. You know about Planck's law, that people chewing on the side with minimal vertical dimension of occlusion. It's very understandable, very clear information. So, but we can find the same information in this very old book. The year of this book, it's 1977. It's Garrett Gelb textbook, and we can find information about muscular chain exists between cranium and shoulder guide. Yeah, and now we can see it on a CBCT image. Yeah. Okay. The line of symmetry, all mandible moved to a patient left, but okay, it's asymmetry on a soft tissue, because on the right side we have a bigger vertical dimension of occlusion, and a lower side less vertical dimension, and you can see how soft tissue looks different on both sides. On the right side, we can see some jaw line. On the left side, we can see free soft tissue. Of course, it's the same patient. It's the same CBCT, narrow airways. But look, if you look on this CBCT from behind, you can see that that neck region isn't straight. The second clinical case, very big asymmetry. The mandible moved to left. The symmetry on the nose, lips asymmetry. So look on the neck region. the same deformation. Of course, if mandible moved on one side with the tongue, of course, our neck must react on this, because it's this structure is very near. It's connected structures. And what we can find on the neck region else, of course, it's Eagle syndrome. Yes, it's elongation of stela hiatus ligament. Very big, very present. So everything what we know about facial aging present on our posture. The functional asymmetry, it's one asymmetry. My patient can't have problem in one region asymmetry on a cranium region, but totally symmetrical all body. It's impossible. Of course, we know about aging of our posture. Yes, the direction of these changes. This is my new article in journal Aesthetic Dentistry, article about relation of facial symmetry and posture in neuromuscular concept, because all diagnostic here we made on K7. So look, this is a patient in an article. She is an orthodontist, but in other side, she is professional dancer. So everything, of course, her posture and muscle tonus and muscle condition, it's very good. She's very active and very sports girl. But look on her face. Of course, you can see that mandible and lower lip move to the right. Okay. When she smiles, we can see the angulation of upper arch. The asymmetric smile. On it is. I see. I don't have buccal photos in this region, but first class on this side and second class on this side. Okay, first and second. So we can transfer on information in a program and connect information about facial aesthetics, about dental scans, dental digital model, and bone structures. Yeah, we can see our symmetry. Okay. And this is her back. Yeah, it's information from German device DIRS. It's non-rentgenology device. It's a body scanner. It's a back scanner. It's work the same. So, and program based on information of this scan, modeling the form of our vertebrae column. Okay, And on the right image, I connect information from Ray Scan. It's a face scanner, from CBCT, and then information from DIRS in one system. So I have all body images and connection about mandible position, neck, and all body posture. Okay, then we continue dental diagnostics. So it's axiography, digital. So the right TMJ have a less range of movement. So originally, when she opened a mouth, the mandible moved on the right. So it's all diagnostics on K7, chewing, and electromyography. And you can see that left temporalis anterior muscles work very active. And left masseter 2. Yeah. So I can see muscle asymmetry here. So it's muscle dysfunction. Okay, what I want to do, I need to change mandible position. In this case, I use TENS because it's neuromuscular. I work here in clear neuromuscular concept. I find neuromuscular trajectory and record myocentric. The mandible position on a neuromuscular trajectory. Then we model in ExaCAD full anatomy dental orthotics. Yeah, we use mill machine. Okay, now we have two sets of dental orthotics, transparent and tooth color. It's not very important. She's dentist, and we made two pairs of orthotics, but usually we made one. Okay. Yeah, you can see orthotics on the teeth. Normal tooth anatomy. It's very important for central nervous system. You have to feel the tooth surface similar like natural. New optic axiography, and now you can see that in mandible opening, the tracks very similar, and the mandible don't move to the right. It's new neuromuscular diagnostics, velocity, not ideal, but looks better. Looks much better, but it's just the first step. Okay, maybe after some time we can find ideal records, but not now. So new electromyography. So you can see that the temporalis muscles don't work so big. Then the main muscle, it's masseter, so it's normal. New mandible position with orthotics. Before, after. And new diagnostics of a posture. Look on a shoulder position here. Here it's totally changed. Facial aesthetics. Symmetry much better. a little improvement of symmetric of smile. And we can compare here to 3D scan. Look how we can change. Of course, she don't have any except weight. So this is it's not double chin, it's just a tongue, position of tongue. But you can see how we can influence on inframandibular region. And I already told to you that it's not only it's not a photo, it's 3D object. And now I can compare very precisely two images. For example, smile before and after. And I can precisely, very precisely, look the difference. Check the difference, compare two images. We can see that all soft tissue of lower jaw move to the left. Now we can calculate changes in soft tissue in inframandibular region, the soft tissue of cheek, lips. So it's lips before. Oh, this is after. This lips before. And it's not similar. Before and after. The symmetric lower lip. This is collecting all information about facial aesthetics, body posture, and electromyography of joint muscles. And at the end, the compare of collected information of facial scanners, CBCT, and body posture. So body scanner, back scanner, German Deere appliance. Yeah. And in the end, small video, I turn off the sound here because last year I add some music in my video. But okay, now we okay, and I don't turn on the music because last year the YouTube don't approve show my presentation because I use some licensed video. In originally there are music, maybe you know this song, it's Supergirl. I will not read this information. You can read by yourself it. This is our article. This is our orthodontist. I already talked about this clinical case. So it's a facial scanner. So it's a back scanner. DIRS is a diagnostic complex with bodopodometry, electromyography of neck. So it's just a part of DIRS diagnostics. It's wallowing, 5 scan, change mandible position. You already milling the neuromuscular cortex, you already know about it. Okay. New posture. It's just a video presentation of my new article and clinical case. Very beautiful girl. So now she have new facial aesthetics, new symmetry, and new posture. Okay, thank you for your attention. I hope everything is okay.
It's okay. Thank you, Stanislav, for your presentation, for your approach and postural and neuromuscular connection. It's very remarkable your view of rejuvenation. Thank you so much.
Thank you.
Okay, can everybody hear me?
Yes.
According to schedule, now we're going to take a lunch break. And after that, we'll have the next presenters. And we'll hear each other shortly, if that's all right.
Hello, Nazim. Hello. Nazim.
Hello, hello, hello,
Hello, Nazim.
hello, hello.
Please,
Can you hear me?
please start now.
Yeah, sure. Hi, everyone. This is Nazim John Tugunov. I'm from Faculty of Dentistry, University of Hong Kong. And today I will be moderating today's session, which is 13. And I'm honored to give a stage to the next our presenter, who is Professor Raju from India. So the topic of today's presentation is Whiter's salivary diagnostics. So, Prof, shall we start? Prof Raju, shall we start?
Sorry, yeah, we can start. With the
Yeah.
Yeah, please. Can I go to the presentation?
Can you start sharing the screen?
Yes, I'm just doing that.
Yeah. Okay.
One moment. It's not allowing me to share.
It's not allowing you to present.
Yeah.
In the bottom of the screen, you have okay. You have a few buttons. Oh, okay, we can see it.
Yeah, now we can see your screen, Prof. I think you can start.
Yeah. It's gone to the last slide. Okay, just give me a moment. Let me just wait.
Yeah, Prof, it's fine. Take your time. Take your time.
Do you require assistance?
Just a moment, please, because it's not coming on in a full screen mode.
That might be because you're trying to use the application instead of trying to share your whole screen. When presenting,
so, you suggest I share the whole screen?
Yes, when presenting, you need to choose, instead of window, you need to choose entire screen. Select the screen and press share.
Thank you so much. Just a moment. Sorry, it's not allowing me to share the entire screen.
When you press the present now button, there are 3 tabs that you can choose from: Chrome tab, window, and entire screen.
Right. The tab, the window, and I pressed on the entire screen, but I'm unable to share. Can I go ahead with the window since it's allowing me to share the window? Can I just go ahead? I think it will be easier.
We cannot hear you. It's too lower the volume. Could you speak up a little?
Yeah, I said, can I just go ahead with sharing the window, because either way the slides should be visible in the window.
Okay.
Right. Okay. Sorry, but for some reason the full screen is not working. So the title for first of all, thank you all for having me on as a speaker. A special thanks from India and Dr. Kalha sends his regards. The flu season is on in India. So all of you, I hope, have had a wonderful lunch, and along with lunch comes a little bit of saliva. And the title is Salivary Diagnostics with a Salivary Diagnostics. Essentially, I'm looking at where is salivary diagnostics going. So let me start off from what Mandel said in 1990. He says saliva lacks the drama of blood, the sincerity of sweat, and the emotional appeal of tears. Hence, it is probably does not get the request that it requires, and everybody ignores its presence and only feels it when it's absent. So my story with salivary diagnostics, of course, start off with Dr. David Wong's book on salivary diagnostics. I was a postgraduate student at that time, and we had this book which for some reason nobody used to issue, and I was the only person who used to sort of borrow this book from the library and read through it. And I learned a lot of salivary diagnostics by doing. Sorry,
Professor, can I interrupt you a little?
Sorry? Yeah.
On your PowerPoint, could you go to the slideshow that is on the top, the slideshow text? Yes, press it.
Yes.
Press on slideshow.
I have.
I'm not seeing
Yes.
it. It's not. Oh yeah, now it is.
From current slide.
And from no. Set up slideshow. Do you have a set up slideshow option? No, on the slideshow bar. Yes, that one.
Yeah,
press
set
it.
up. Yes. Yes.
I'm waiting for the window to pop
That's
up.
pressed.
Once you press that button, you should see an option called browse by an individual window. Press it again.
Yes,
It did
correct.
not open. Can you see it?
Yes. And say OK.
Okay. Yeah, select that option, browse by an individual window, and press OK if you see it. I cannot see it on my screen.
I pressed OK.
Okay, and now try to start the slideshow from the bottom right corner. Yes, press on that. There you go. Have fun.
Yeah. Thanks so much. Okay, so this is the book which essentially started me on the path to salivary diagnostics. So we should start with the question that is there a need for a new diagnostic fluid because blood is traditionally preferred. There are numerous modalities which work on blood and serum, which are doing good for diagnosis and prognosis. They're widely accepted, they're reproducible, and are the cornerstone of what is today accepted medical care. However, the problem comes because drawing blood is painful. In a lot of patients, it causes anxiety, and it requires a special setting, a lab or something. So why saliva among all the other fluids? It contains a broad range of biological markers. You have DNA, you have RNA, you have hormones, antibodies, and after blood, and probably it has the most amount of metabolites which are diagnostically significant. It's easy to collect, and it provides very broad health insights across a various range of diseases. I'm not going to be talking about the rice test. The rice test was used to check if you're true or false. If you're able to swallow a ball of rice, you're true, otherwise it's false. Somewhere around 1912, we had the detection of the microorganism tuberculosis from saliva. 70s to 90s, we saw a lot of salivary diagnostic tests for cortisol, testosterone, and estrogen being available in a research setting. And in the early 2000s, we were able to identify salivary markers for breast cancer. All of us know about the NIDCR funded efforts between 2002 and 6, wherein development and validation techniques for salivary based diagnostics was looked in, and the intention was to look at 4 disorders: oral cancer, COPD, acute myocardial infarction, and HIV and tuberculosis. There have been immense gains that have been made by these initiatives. The concept of lab on chip devices essentially came out of this initiatives. There are enough research studies which prove that saliva is a potent diagnostic fluid. However, the problem is the utilization of saliva for diagnosis in real world scenarios is yet to be reached. So we're almost 15 years past the initial research, but we have not yet bridged the research gap, so to say. So currently, where do we use saliva? Caries diagnosis, caries activity tests, it's regularly used. Periodontal diseases, especially in the identification of the red complex microorganisms and their prediction. There is a new ELISA test, which is sort of brought in, which can identify the red complex microorganisms at a very sensitive level and predict whether the disease is going to be aggressive or less aggressive. We can look at accelerators and reducers of periodontal inflammation, including antioxidant levels in the saliva. We have at CIDS developed antioxidant level tests and kits, which are showing a good degree of sensitivity and specificity. Disease of the salivary gland, such as Sogman syndrome, of course, obviously, and probably the only condition wherein there is an approved screening test for saliva, or of course the salivary HIV test kits, where various test kits that are available commercially, and with the advent of the COVID pandemic, COVID tests through saliva have also become extremely popular. But what is the problem with salivary diagnosis? Problem basically is in the levels of molecules of interest. For example, if we could consider blood sugar levels, it's something that we are currently working on. If fasting blood sugar level in serum is around, let's say 100 to 120, in saliva we are able to probably get around 0.1 to 2 micrograms, which is very less. So identifying of low levels is a problem. Saliva also varies between individuals. Oral habits are known to influence the complexity of saliva, the food that we eat, smokers versus non-smokers. We have also done tests wherein there is a difference in saliva between the 2G spectrum and the 3G spectrum. Thus, reproducibility is hugely hampered, and there are variations in saliva that's collected at different time periods. The saliva that's collected in the morning is slightly different from what is collected in the evening and in the afternoon. So consistency of the molecules of interest is not there, and extremely complex salivary components are also going to be there. So a lot of these challenges have been overcome with the advent of the omics era. So salivoomics is the new iteration of salivary diagnostics. So you have the epigenome, the transcriptome, the genome, the proteome, the microbiome, and the metabiome. This is, of course, RNA extracts from various fluids. And if you have a look at it, you find that serum has the most of extracellular RNA, that is around 1603, whereas saliva has around 256, probably the second behind serum. So let's look at what we are working at. At our institute, we are part of a larger study group which is examining the salivary microbiome in patients in oral cancer and pre-cancer. We have identified a group of around 100 individuals with oral cancer and pre-cancer, and we are looking at what is the changes in the microbiota. There are two species which we have identified by 16S RNA sequencing. That's Prevotella and the Fusobacterium species. And we are looking at identifying the metabolites of these bacteria as markers of oral cancer. This is in a very initial stage, but it is quite promising. So hopefully in the next 2 to 3 years, we will be able to bring out a realistic diagnostic methodology for oral cancer using this. This, of course, are the various extracellular RNAs that are seen in oral cancer and pre-cancer. In India, oral cancer and pre-cancer is a huge health challenge, probably not so much for you guys. It's the largest cancer that is there, and huge mortality and morbidity that's involved. That's why we thought we'll look at oral cancer and pre-cancer. Of course, oral cancer identification using saliva is not new. Around 2008, Dr. Wong's team identified around 300 mRNAs, and around 180 of these have been identified as common. They also found changes in 4 mRNAs consistently in these patients with focus on lab and chip diagnosis. Other than that, various other researchers have found increased levels of MMPs, which helps in the metastasis of oral cancer. Recent research shows the P2 and the ZAG2 and the CIFRA2, TPA, and CA125 are significantly increased in the saliva of patients diagnosed with oral cancer and pre-cancer, and these are being looked at as salivary markers of oral cancer and pre-cancer. Other than oral cancer and pre-cancer, pancreatic cancer, researchers have demonstrated that 4 RNA biomarkers, that's the KRAS, MDB3L2, ACRV1, and the DPM1, have been specifically identified in pancreatic cancer patients, demonstrating a sensitivity of 90 and a specificity of 95. Gastric cancer patients show increased levels of cystatin D, TPII, and DMBT1. PSA, MIR21, MIR141, constantly elevated in the saliva of prostate cancers. Non-small cell lung cancers, people have demonstrated EGFR mutations in the saliva of these patients. And the recent study by Zhao et al., there are 16 candidate proteins which are there, which can discriminate between lung cancer patients from healthy individuals and are proposed as effective biomarkers. Again, the sensitivity and specificity is in the range of 90 to 95%. Then this area of interest for us here is salivary diagnostics using biochemistry. There are more than 300 proteins and molecules of interest which are there. Type 2 diabetes is a major health concern for us in India, other than oral cancer, which I was talking about. And we have looked at examining the saliva as a tool for the diagnosis of type 2 diabetes. We initially started working with the biochemical kits, but again, the problem was the biochemical kits do not have the Godpod method does not have the sensitivity to detect extremely low levels of sugar that are there in saliva. Hence, we had to look at developing the ELISA-based methods. We were able to succeed with the development of ELISA-based methods, but realistically speaking, the ELISA-based methods cannot be used on a regular basis by a patient, thus defeating the entire purpose of looking at saliva as a fluid, wherein the patient himself is able to take the sample and look at his sugar levels. So low salivary glucose levels were of course an hindrance. Now with the development of the microfluid and the nanotechnology, we are working with a biotechnology department to develop a microfluidic nanotechnology based chip for glucose monitoring. We have tested it in around 50 patients, and we have got an extremely good correlation between fasting blood glucose and the salivary blood glucose. However, the correlation between postprandial blood glucose and salivary glucose for some reason is just not forthcoming. So we are looking at changing technology to see if we can do something to get a good result. However, a problem could be that the timing. Usually the postprandial glucose tests for serum is usually done at around 2 hours afterwards, but in saliva, depending on the diet, we are able to find dietary products still there which could contribute to salivary glucose. So it is something that we are testing just to see how good we can bring about seriously good test kit. Our plan is to include these chips onto complete denture patients, the elderly, and sort of do a continuous monitoring of salivary glucose along the levels of the continuous glucose monitoring devices that are there using serum, which are commercially available. So these are the other areas. You have endocrinology, you have nephrology, you have autoimmune diseases, you have forensic medicine. Interesting work that we are doing in forensic is using 16S RNA sequencing to identify individuals based on their salivary microbiome. And I'm happy to share that the results are extremely promising, and maybe at over a period of time, we should be able to develop a way of identifying individuals from the salivary microbiome rather than looking at fingerprints and DNA sequencing and those sort of devices. Periodontal diseases, caries risk assessment, and orthodontics and dentistry is something that we are all pretty much exposed to in a regular period. You know, you have your risk assessment tests which look at salivary microorganisms, salivary pH, the pH changes brought about by the microorganisms, which today dictate how caries should be not necessarily treated but managed, and monitoring therapeutic drug levels and poisoning levels, and also diagnosing levels of alcohol consumption and drug abuse is something that is ongoing process. It is used widely by the law enforcement and with good degrees of sensitivity and specificity. So what are the emerging fields in salivary diagnosis which will probably guide salivary diagnosis in the next decade or so? So you have a new emerging field that is metabolomics, which looks at salivary metabolites, the end products of salivary metabolism, being able to diagnose various diseases. As I just mentioned, we are working on this specific concept and looking at the metabolites of the two microorganisms to see if we can bring about a device which could detect oral cancer at a very early stage. And of course, microbiomics. Essentially, microbiomics in saliva became very popular in salivary diagnostic oncology with the work on early resectable pancreatic cancer identification, which was done by means of microbial profiling or the microarray. And two markers, the Neisseria and the Streptococcus mitis, have shown good specificity and sensitivity. The victory of salivary diagnostics will only come with the acceptance of point of care devices. Till we get point of care devices which are able to produce reproducible results and which can be done by the patients themselves, salivary diagnostics is still going to face a whole lot of challenges. An interesting new concept that's probably also coming out is liquid biopsies, which are looking at detecting circulating tumor cells and DNA fragments for tumor diagnosis. One of our postdocs is working on liquid biopsies for oral cancer diagnosis. But the results, again, a little bit inconclusive, because oral cancers are easy to diagnose, but to predict which oral pre-malignancies are going to transform and which will not is something that will be of huge impact on saving patients. Pre-malignant lesions are not giving us good results, but as cancers, we are getting good and reproducible results. So this is the main problem, that there is a whole lot of research on salivary diagnostics which promises a lot, but the final the holy grail of diagnosis is to bring about kits which are accepted and which have acceptance from various agencies, be it the FBI, be it the ADA, which are accepted diagnostic kits. So till that gap is reached, saliva as a diagnostic fluid in clinical practice is slightly difficult thing. So that's why I said this is in search of the holy grail. Abundant research has proven effectiveness of salivary diagnostics in numerous oral and systemic diseases. Omics era has, of course, led to a huge resurgence in the field of salivary diagnostics with the promise of novel salivary-based diagnostic solutions, not only for oral diseases, but also for systemic diseases. However, the challenges remain. The challenges of standardization. Now, as I was talking about, when do we collect the saliva? How do we collect the saliva? And how the saliva is stored? All of this bring about changes in the quantum of the interest molecules that are there. And because the interest molecules are found in very minute quantities, the variation will bring about a confusion or becomes a confounding factor that needs to be addressed at a huge level. And should we look at a competition between serum and saliva? In my personal opinion, I don't think so. It should be serum along with saliva. following the theory of horses for courses. We look at serum where serum gives us the good results. We look at saliva, especially where it is very sensitive in diagnosis. The need is to identify areas where salivary diagnosis is most likely to succeed and bring about tests to prove the effectiveness of saliva in a real world clinical scenario. One test kit would sort of open up the gates of the dam for salivary diagnosis is my personal feel. I thank you all for your patient hearing, and thank you again for this opportunity.
Thank you, Prof, so much for your presentation.
Thank you, Dr. Nozim.
Yeah, thank you so much. Shall we give a stage to our next presenter?
It will be just a few more minutes because Mr. Shashidira's presentation ended faster than anticipated. We still have a few more minutes before we can confirm the next participants.
Yeah, sure. All right.
Thank you very much.
All right, thank you.
Sorry, I thought it was a half an hour presentation, so that's how I prepared. Sorry.
No, there is no problem. It was supposed to be like 45 minutes, and it's a little earlier. If you'd like to say a few more words while we wait, there would be no problem. I don't think anyone has something to say about it.
No, Marian, thank you so much for the.
Okay, no problem. Thank you as well for your presentation. Hello, can everybody hear me?
Yeah, we can, Marian.
Sorry for the inconvenience. We will need to take another 30 minutes break until the next presenter will be available. Sadly, we couldn't get a hold of the next presenter from the program, so we invited someone to take his place. Shortly, we'll present the next doctor, and hopefully everything will be okay. And sorry for the inconvenience.
Hello, Professor Ronkin. Thank you for your contribution at InnoBioDent conference. Thank you so much. Please.
Prof, we cannot hear you, Prof. I think your microphone is turned off.
Dr. Konstantin Ronkin. Oh, okay. Now the microphone is open.
Hello. Hello. Can you hear me now?
Yeah,
Yes,
now we
we can hear you.
Do you?
Prof, 1 minute. Can I introduce you? My name is Tugunov Nozumjon. I'm from Faculty of Dentistry, University of Hong Kong, and today I will be moderating today's session. Welcome everyone, and thank you very much for your contribution, and thank you for joining us today. Well, let me introduce Prof. Konstantin Rankin from the United States, and today's presentation entitled "The Sleep Epidemic: The Role of Dentists in Prevention, Diagnosis, and Treatment Obstructive Sleep Apnea." Prof, thank you so much. Thank you for joining, and thank you for your contribution. I think I can. You can continue. You can start your presentation. Thank you so much.
Thank you. And I just want to make sure that everybody see the presentation, the screen, and they hear me, right?
Yes.
Yeah, we can see your slides and we can hear you. Thank you.
Excellent, excellent. First of all, thank you for very much for the invitation to speak at this conference, and I'm grateful for this opportunity. Thank you very much. All right, so the sleep epidemic and the role of dentists in prevention, diagnosis, and treatment of obstructive sleep apnea. All right, how I can advance this? Hold on.
You can use the arrow keys.
All right. Do you see this slide, right? The obstructive sleep apnea is common disorder among adults and children. In 2018, the American Center for Disease Control classified sleep disorders as a public health epidemic. Sleep disorders affecting people of all ages, men and women, almost everywhere, and it is silently killing us. Silently, we don't know about this. So a couple of numbers. 24% of men suffer from sleep apnea, and 9% of women at the age from 30 to 60 years old. And this is very, very conservative numbers. Why? Because 90% of people with obstructive sleep apnea not diagnosed. 90% of OSA not diagnosed. And 75% of them have a severe sleep apnea. Severe sleep apnea. And let me go back. Kids also have sleep disorders. Around 11-12% kids snore, and traditionally reported to range between 1 and 5% with a risk prevalence occurring, with the peak prevalence occurring at age of between 2 and 8 years of age. Right? Kids also have a sleep issue. So, perhaps better topic for my presentation would be not a sleep epidemic, rather than sleep pandemic. It's everywhere, and it's killing us more than COVID and other health issue. Obstructive sleep apnea is characterized by recurring narrowing or collapse of the pharyngeal airway during sleep, resulting in a substantially reduced or complete cessation of airflow, despite the ongoing breathing effort. Loud snoring is a typical feature of obstructive sleep apnea, and in most cases, the culmination of respiratory events is associated with brief awakening from sleep arousal. Obstructive sleep apnea is associated with a narrow airway with major comorbidities, including the daytime sleepiness, impaired cognition, and poor quality of life. And increased motor vehicle accidents. Patients with obstructive sleep apnea are 3 to 15 times more likely to be involved in a car accidents. There is strong evidence to suggest that obstructive sleep apnea is an independent risk factor for severe cardiovascular outcomes. According to the literature, comorbidities of OSA with cardiovascular disease is 40%. With arrhythmia, 50%, drug-resistant hypertension, 75%, cerebral accident, 84%, like strokes, right? Heart attack, 50%, diabetes type 2, 75%, fibromyalgia, 80%, impotence, 50%, kidney disease, 50%. And for us, it's very important, TMD, temporomandibular joint disorder, 75% of correlation. It's huge, right? Huge. 75%, and according to the literature, between 75 and 95% of patients with TMD have obstructive sleep apnea, and 75 to 80% of patients with OSA have a temporomandibular joint disorder. And this is a tons of literature. For example, this article saying that 75% patients with TMD had a clinical signs saying that they had breathing problems during the night. This study, 75% patients with OSA suffered from chronic pain related to TMD. Another study, this study, even like more, 95% OSA patients had a TMD. So it's many other articles supported this percentage. So that's why the rule number one, at least in our clinics, all TMD patients should be screened for obstructive sleep apnea. And until proven otherwise, they suspected patients with OSA. So until we proven that they don't have it, obstructive sleep apnea, we treating them as a patients not only with a TMD issue, but also with a sleep apnea issue. The life expectancy probability of patients with untreated sleep apnea diseases as the stage of apnea deteriorates, it's getting worse and worse. According to this study, the probability of 20 years life expectancy of the patients with untreated mild sleep apnea is 95%. But while the patient with untreated severe apnea have a 20 years life expectancies of only 58%, half, almost half of the patients not going to survive in 20 years. According to the literature, also, on average, the life expectancy of those suffering from obstructive sleep apnea, let me put this slide, obstructive sleep apnea is 20% less than that of healthy individuals. For example, if the average life expectancy of people in the United States is 80 years, then the average life expectancy among OSA patients is only about like 64 years. So a huge difference, right? So what we can do, first of all, to identify, remember, 90% of sleep apnea is not diagnosed. And the best place to do this is dental office. Dental office. And this is statistics. Almost 75% of Canadians visit a dentist in 2009. 61% of Americans visited dentist in 2011. 91% of children in Canada visited dentist. 81% of children in America visited the dentist. So 84% of teens in Canada visited dentists in 2011. So it means that it's so many patients coming to us, and we have opportunity to diagnose, to detect the obstructive sleep apnea. And you will see why it's also important for the dentists to do this. Who we should screen? First of all, it is necessary to take into consideration three main risk factors that increase the likelihood of obstructive sleep apnea: obesity, male sex, and aging. Okay, when we're talking about obesity, deposition of fat around the pharyngeal airway increase the collapsibility of the pharyngeal airway. Fat deposition around the abdominal leads to reduction of the functional residual capacity. Lung volumes associated with diminished oxygen stores, which would contribute to ventilatory control and stability, like we call this high loop gain. Male sex, increased fat deposition around the pharyngeal airway. The majority of the available data suggest that the male sex has a high predisposition to obstructive sleep apnea. Increased length and collapsibility of the pharyngeal airway, and also to compare to the women, hormonal differences between men and women. All these factors kind of make the male more prone to the sleep apnea. That's why the percentage-wise is twice more male suffer from sleep apnea. And aging. The frequency of the sleep apnea increases with the aging and reaches the plateau after 65 years. And when we see in our patients, we can notice like dental signs which correlated with sleep apnea. And that's why we see the high correlation between malocclusion, TMD issues, and sleep apnea. We see patients with retrognathia, high palate, narrowed arches, and enlarged palatal tonsils, adenoids. Normally, adenoids and tonsils start to get smaller at age of 5, and by age of 12, they almost disappear. It's supposed to be in normal life, but we can see a lot of kids, a lot of teenagers and adults with adenoids and tonsils, enlarged tonsils, and this is a reason for this, and it will make them to breathe through their mouth. Not that we have a problem with the nasal breathing with these individuals, and they prone to have a sleep apnea. We can see patients with a long, soft palate and uvula. This is another sign. Crowding of the teeth, overbite, distal position of the mandibular, broxers, clenchers, oversized and scalloped tongue. Oversized tongue occupies room in the oral pharynx. And statistically, 70% patients with OSA have a scalloped tongue. We just need to differentiate them from like other reasons for scalloped tongue. For example, small oral cavity or problems with thyroid gland. We will talk about this. This is a study shows that the tongue scalloping is predictive of sleep pathology, confirmed by PSG. %75% of GERD patients have OSA. As a result, we see patients with acid erosion like this or like this, right? What are we doing? We are restoring them using like composite bonding, so using veneers. In many cases, We're not asking, we're not checking for the sleep disorder. But again, 75% of these patients could have sleep apnea issues. Symptoms, signs and symptoms. Daytime sleepiness. Headaches, especially in the morning. Frequent awakening. Hypoxia during the night. High level of CO2 and acidosis. Overweight. We talk about overweight already. Metabolic syndrome. Respiratory stops while sleeping. If the partner, the bed partner, can tell us that this type of things happen. And snoring. And snoring. Snore is not normal. It's already some disorder. It's not normal sleep. Hyperthyroidism. 11% of patients with the OSA have a hyperthyroidism. Again, as a result, we can see the scalloped tongue when you don't have enough of thyroxine or triiodtyronin in a patient system. So we need to screen patients with all these risk factors: weight gain, obesity, men's sex, age, family predisposition, alcohol and sedatives, narrowing of the upper respiratory tract, bite pathology and temporomandibular joint disorder, smoking, endocrine diseases and metabolic disorders, and other. So it's huge group of patients we supposed to screen for the obstructive sleep apnea. Dentists can play major role in preventing and development of obstructive sleep apnea. Timely orthodontic development of the cranial skeleton, jaws, and airway. This is what we can do. Orthodontic treatment without permanent teeth extraction. Establishing the neuromuscular position, the physiological position of the lower jaw for any dental treatment, which will result to enlarge the volume of the oral cavity, make more room for the tongue. And if we're doing this, the airway will be open, more open, all right? Because most of us have a back distal position of the lower jaw. And most of the pathology, at least in our part of the continent, we have a class 2, division 1 or division 2, but we have a class 2 distal position of the lower jaw. When the jaw goes back, it also goes up. As a result, we have a very small oral cavity, and the tongue doesn't have enough room. And the tongue can go where? It can go only downward, and we can see the double, triple chin, especially like when the person doesn't have a extra weight, but still have a double chin. This is tongue. tongue doesn't have enough room. And also tongue goes backward and close airway or make it smaller. So that's why when we treat patients, doesn't matter for what, we can treat, we can do just single restoration or multiple restoration or full mouth reconstruction. It needs to be done in physiological, restored position of the lower jaw. And normalizing nasal breathing is very important because the mouth breathers have a very narrow arches, very high palate, and when we try to treat them, it works against us. So normalizing nasal breathing is very important. Why I'm a dentist, why I'm talking about this? Why it's not ENT? Because when you send kids with adenoids to ENT, most often, very often, I see them back, and ENT doctor just saying, "Okay, so let's wait. Let's wait. It will go away." But the problem is, like I said, by age of 12, probably it will go away if we remove the cause of this. But for all this time, for 12 years, the kid will suffer, and it will make the jaw very small, oral cavity very small, malocclusion, all this stuff. And then we're dealing with sleep apnea issues and maybe in the future TMD issues for these kids. So nasal breathing is very important. This is our goal, to kind of normalize the nasal breathing for these patients to prevent TMD in the future. All right, now we're moving in treatment, and obviously dentists play a huge role in a treatment of OSA. So, and historically, the sleep doctors is like mostly it's like cardiologists, pulmonologists, all this type of doctors, and realize that sleep apnea, especially obstructive sleep apnea, related to the oral cavity, related to the position of the lower joint development of all cranial skeleton. The gold standard for OSA treatment remains CPAP. This therapy involves delivery of pressurized air to the upper airway during sleep. Pressurized air acts as a splint open the upper airway, preventing it from collapsing during sleep. Oral appliances are the leading device alternative to CPAP therapy. Mandibular advanced devices, MAD, open the airway by moving the mandibular forward. Tongue moves forward with the mandibular. It increases genioglossus muscle activity to open upper airway, increase the activity of pharyngeal constrictor muscles to open middle airway, and the more than 60% of patients keep using MAD after 10 years. The study was done to support this statement. More than 60%. Just remember this number, because when we're talking about efficiency of the appliances compared to the CPAP, we can see that it's pretty equal. So this study was done before the study. So let me say that the action of mandibular mandibular and advancement results in increase in pharyngeal airway space and reduces airway collapsibility. Oral appliances have a demonstrated role in improving snoring, obstructive apneas, hypopneas, and oxygen desaturation measures. Oral appliances also have a demonstrated benefit on health outcome measures such as daytime sleepiness or blood pressure. All right. So this is what oral appliances can do. Now, go back to this study. According to the study, over a third of patients will show a complete response to oral appliance therapy with a reduction of AHI less than 5, meaning it's like complete remission of sleep apnea. Another third had a 50% reduction in AHI. And medical professionals, they consider this as a success of the treatment. And the last third will not achieve 50% of reduction of AHI. So this is kind of failure. So 2/3 we can consider as a successful treatment, right? While the efficacy of CPAP is generally high, in the real world, long-term health effects of CPAP are likely to be compromised by low compliance of the patients and suboptimal hours of treatment use. CPAP has a high efficacy, low adherence. Oral appliances have a moderate efficacy, high adherence. As a result, in overall equivalent, we have an equivalent treatment effectiveness of oral appliances and CPAP. And that's why it's very important for us to use oral appliances. And it's so many of them. Last time when I checked, I found like 140 plus oral appliances. They're all different. It's like monoblocks and 2 plates connected with some sort of mechanism. As other variations include the range of degree of advancement and lateral movement, vertical opening, fabrication material, and the amount of occlusal coverage. So it's not like one device for every single patient. It's like different devices and they have their own indications to use. mostly we use oral appliances to treat mild to moderate obstructive sleep apnea, but also severe sleep apnea for the patients who can't tolerate to CPAP therapy. Mandibular advancement devices effective in reducing the frequency and duration of episodes of complete or partial respiratory arrests, respiratory effort-related arousals, snoring, increase in the degree of tissue oxygenation during sleep, improve side effects of the sleep apnea. But the biggest challenge with med treatment, and not only med treatment, and other treatment, we're using now other modalities, other intraoral modalities like DNA or Vivas appliances. And the key point here to find the optimal mandibular position for the med fabrication. This is the key. This is the most important thing, because on one side, we need to move the lower jaw in a position to maximum for the maximum opening of the airway. But also we need to take in consideration the condition of the temporomandibular joint and muscles. We don't want to move too far forward to stretch too much muscles and move the head of the joint too much down and forward, right? So most data suggested to advance lower jaw from 25 to 75% from maximum protrusion. Traditionally, dentists use the George gauge or other gauges to establish the mandibular position for med fabrication. The problem is that some publications suggested that to use George gauge to establish mandibular position for the oral appliance fabrications, worsening of the AHI. Also, we can see a rotation in the cervical spine, hypertonicity of the masseter muscles, bite changes, cervical spinal deformities. So that's why the second best technology available, which can help establish the mandibular position in the at least sagittal plane by titration of the lower jaw position while the patient is taking PSG test during the sleep, right? So we can remotely to use this device to move incrementally lower jaw forward while patient sleeping. This device called Matrix. It's allow us to find an optimal mandibular position in the sagittal plane according to the PSG data. And especially medical professionals, they think that is like golden method to find the optimal position of the lower jaw. And it is. And it is good technology. It is good technology. But we use neuromuscular method of determining the physiological position of the lower jaw to treat obstructive sleep apnea with the restoration of the muscle balance with the help of ultra-low frequency electroneurostimulation, electromyography of the chewing muscles, as well as electrokinesiography, allow us to move jaw in the most accurately position. Like this. This is a bite, and we can use this bite to fabricate the oral appliances. So, in 2017, we conducted the study to determine the effectiveness of the physiologic bite position of the lower jaw in comparison with the matrix position for the fabrication of the sleep appliances. And it was 32 subjects, 5 women, 27 men, with average age 49 years old, and the range was between 27 and 72. All subjects selected for this study were diagnosed with obstructive sleep apnea. So I'm not going to explain the whole study, but I will show you a couple of slides. As we see here, the physiological occlusal position in the point number 2, you can see number 2 here, right here. This is a physiologic occlusion what we determine, and all other like 3, 4, 5, 6. This is a different matrix position. Physiologic, this is matrix position, and then we took a EMG, and we found that the best matrix position is number 5 according to the EMG of the muscles. But the physiological position, this is position number 2, has a best position, best electromyography characterization, and we choose this position to fabricate oral appliances. The average physiologic bite position was 3.26 millimeters forward from the habitual trajectory. The average matrix position was 3.4 millimeters more forward than the average physiologic bite position. For this patient, for example, we can see this is 2 millimeters difference between physiologic bite position and the best matrix position. So, average is 3.4 according to this study. It's 2 conclusions of this study. The first one, the average, this study confirms that using the described method, neuromuscular method of physiological bite registration allows for the reduction of the protrusion of the lower jaw during the treatment of OSA with med appliances. According to the study, the average physiological bite position of the lower jaw was 3.4 millimeters distal to the matrix position. And second, the physiologic bite position is an effective way to determine the position of the lower jaw for all planes for the successful treatment of obstructive sleep apnea. It is more comfortable position for muscles. The average EMG in the physiologic bite position was 59% lower than the best matrix position. So it's better for the muscles, and it doesn't need, we don't need to move the jaw too much forward. So like I said, according to the study, 3 millimeters more distal from the best matrix position. So in the conclusion, I have to say that we must take into consideration not only anatomy, but also physiology of the whole body when we are treating obstructive sleep apnea patients. Thank you.
Thank you so much, Professor Ronkin, for your presentation. This topic is very important, and I kindly invite you to submit a paper in World Journal.
Good. Yeah, we'll work on this.
Thank you so much for your contribution.
Thank you.
At our Congress. Thank you.
Yeah, thank you.
Thank you, Prof, so much for your presentation. Shall I give a stage for our next presenter, who is Prof. Russell Jeffy? Prof. Russell, are you here?
Yeah, yes, I am.
Yeah.
Can you hear me?
Yeah, I can hear you. I think you can start your presentation.
Okay. I'd be delighted to present on this important subject with this important conference. We have contributed chapters to the upcoming book, and I will be talking mostly about nature, nurture, and wholeness. I will be talking about the eternal golden braid that allows for wound healing. Effective, comprehensive wound healing. This means the connective tissue, the collagen, elastin, and glycosaminoglycans are all assembled in the right place in the right way by dendritic cells that are powered by certain essential nutrients and inhibited by other nutrients. By this I mean, nature's ascorbate, and let me see if I can find the slides. Well, I see them on one screen. I should see them on another screen.
Hello, doctor. Sorry to interrupt. You need to present the PowerPoint first. In the Google Meet, we have in the lower part of the screen some buttons.
Yes.
The microphone, camera, and next to the smiley face, there is an arrow pointing up, and that's the present button to present your screen. Press it once.
Okay.
And now you should see a pop-up window, and you can see Chrome tab. The next one is 1 second. You need to press on the entire screen option.
Okay.
Did you find it?
Not quite.
No, that's the raise hand. The button left to the hand.
How about share screen?
Yes.
Share screen.
Okay. And then you will have 3 options.
Okay.
That was the camera.
Okay.
You closed your camera.
Oh, we don't want to do that. we want to open the camera, will be recorded.
Oh, okay. You're on your phone.
I am. I'm on the phone.
Okay. Now we can see the screen broadcast, and you can open your presentation from here.
Okay.
Do you have access to your computer by any chance?
Well, I do. And I think that's what I should be doing right now is coming in on the computer.
Yes, you can join the meeting using the computer. It's way better this way.
Okay. And also, yes, I see my slides. Now, can I get you to see my slides?
No, you did not present them with us. You need to press the present now button.
Okay, I can do that. Oh, first I have to link into the meeting.
Yes.
So, here we go. Presentation guidelines, no. Virtual presentations, contact. No, that was last year. Now,
Okay, I can send the mail right now. Give me
that would be much appreciated. If you could send the email, I will link in just a moment.
Yes, no worries. Just a second.
You're being very gracious.
Well, it's my job. It's I'm the technical lead assistant, and we need to make sure everything is all right and working.
Yes, we want that. So,
okay, I'm sending it right now.
Okay.
And it's just the link for this conference.
Good. As soon as it comes through, I will link to you. I am very appreciative that you're bearing with me. It does take a minute to go through our
yes, it does.
Server and this and that, but I'm sure it will pop in just a moment. In the meantime, I can, here it came. All right. Now, one thing at a time. Here we go. Yes, this looks familiar. And you'll be able to join my name.
Yes.
Allow. Russ. Jaffe. Join now.
Yes. Okay, you joined.
Yes.
And if you can leave from your phone, cancel end the conference from your phone, please.
He already did this.
Yes.
Okay.
All right. Now I should be able to share. Let's see. How can I do this?
Yes.
Here we go. More options. Change
No, not from more options. There is a smiley face. Can you see
smiley face? Yes, I do.
Yes, and the button to the right. It says present now.
Skin tone?
No. Don't press on the smiley face. It's the button next to the smiley face.
Next to the smiley face, present now. There we go.
Press it and
allow to share. I'm allowing it to share. And hopefully
you will see Chrome tab. And next to it, have entire screen.
Okay.
It's in the top of the pop-up screen.
Top of the pop-up screen. That's good. Oh, how about
Entire
this?
screen.
Share this window, right?
Yes. Okay.
No, not quite. We're almost there.
Press right now on that button, the present now.
Present now. Okay.
Yes, press it.
Okay.
Resume
Resume presenting.
Stop screen sharing.
Oh, stop screen sharing. Okay.
Yes. So that we can do it again.
Okay.
Press the press now button that you just pressed. The lower buttons. Okay, that's the one.
Russ is presenting.
Yes. Press it.
Resume
Stop screen
presenting.
sharing. No, stop sharing.
Oh, stop.
Yes, we need to stop it.
Okay. Stop screen sharing. We did that.
Yes. And now we need to do it again.
Oh, okay.
But this time, you need to use the entire screen setting.
Can you let me?
Okay, sure.
Okay, that's the present now.
Do I allow?
Yes.
Allow to share window.
Yes.
Allow to share window.
Now, do you have a pop-up?
Yes.
On the top side of the pop-up, you have three options. Can you press the entire screen option?
Entire screen option. I can look for that. Entire screen option. Oh, this looks like it might be.
Yes, press it.
No, that was the top.
Yes. Now you should see new options. Select the screen that has the power. Or if you have only one, select that one.
Okay, so now go to PowerPoint because I need to activate that first. Yes.
Yeah.
PowerPoint is up. Share entire screen.
Yes. After that, pressing share.
Okay.
Now, activate the power.
Activate the PowerPoint. That's up. No, sorry. PowerPoint is up. Yes.
Okay, now you can begin.
Now we can share?
Yes, we can press the start presentation. No. On the bottom side, you have one button to start the presentation. The bottom on the right side.
The bottom right side, okay.
Yes, that's on the right side. Okay.
It says share.
No, on the bottom.
On the bottom.
On the bottom.
Yes. That one.
Oh, slideshow.
There
we go. Now, go back to the beginning. So you're now seeing, okay. So now I'm ready to begin and very grateful to be here now. I am a physician and a biochemist. I maintain a fellow status in a number of different societies from which you can conclude I either have a Jewish mother or I'm easily bored. You can reach me through the Health Studies Collegium. I am the founder and chairman of PERC, Integrative Health ELISA Biotechnologies, and RMJHRX. That keeps me off the streets and out of trouble. Let's just jump in first with the universal antioxidant that is required in larger amounts today because of the toxins of high-tech living. What we're talking about is nature's ascorbate. This is 100% L-ascorbate, fully reduced and fully buffered. That means it was produced under a nitrogen blanket so that the oxygen in the air, which damages most ascorbate during production, does not harm nature's ascorbate. This renews and repairs better. It is the universal maternal antioxidant. And by that I mean it sacrifices itself so that all other antioxidants can be regenerated. And there are a number of articles, including some that we have contributed to, along with my colleague, Dr. Susan Brown, and a classic article by Englard and Seifter on the bottom of the slides. From 1986, they were anticipating the need for ascorbic acid in biology. It's remarkable that such a small molecule can have so many beneficial effects when it is present in sufficient amounts. And how do you know today how much ascorbate an individual needs? Well, if they're healthy, half a teaspoon, which is 1.5 grams every 15 minutes, or 6 grams an hour, will be sufficient to have most people who are healthy cleanse within an hour or two. If you're moderately symptomatic, twice as much. This would be 3 grams or 1 teaspoon every 15 minutes. And if you're chronically ill, 6 grams, 2 teaspoons every 15 minutes, which is 24 grams an hour, 48 grams in 2 hours. Most people will be able to determine the amount of ascorbate they need to cleanse. The amount you need to cleanse determines how much you should be taking every day. Half to 3/4 of the amount to induce the cleanse. Let's say the cleanse takes 1 hour and it's 24 grams at 6 grams every 15 minutes. How much should you be taking every day? Between 12 and 18 grams spread through the day. If you need this much ascorbate, I suggest in the morning you get a jogger's bottle, you put the amount of ascorbate for the day in that, you fill it with water or any beverage of your choice, and you sip on it throughout the day. The need for ascorbate is dramatically greater because of high-tech living, because of the toxins in the environment. For many, many reasons, the need for ascorbate is greater today than ever. Now, this is over 4,000 people that we studied. I'm going to show you the colors. The color yellow means healthy. They tend to calibrate or have a C cleanse on 5 grams or less. Then minimal symptoms in orange, 5 to 10 grams. Green, 80% of people need between 10 and over 100 grams. And then on the far right, there are a few people who have prodigious oxidative needs, and their antioxidant needs are equally prodigious. So we want to know how much of Mother's Nature's antioxidant is needed. And just to focus in on one specific item, for 1 gram of ascorbate, and you can go through the math, you will eliminate about 10 micrograms of toxic mineral total. Mercury, lead, cadmium, arsenic, nickel. For each gram, you eliminate 10 micrograms. The daily exposure for most people in the industrial world is 20 micrograms, so the first 2 grams per day will help remove the day's daily accumulation of toxic minerals, and your total ascorbate need will be even greater. Now, it turns out there's another aspect that is critically important, along with antioxidant, mostly ascorbate C cleanse. You also need to know about metabolic acidosis and catabolic illness. And you measure the urine pH after rest. The urine pH after rest should be 6.5 to 7.5, and that means you need 2 doses a day. 2 doses a day of 220 milligrams elemental magnesium along with choline citrate. Choline citrate is the secret sauce that triples the uptake of magnesium, correcting metabolic acidosis and correcting catabolic illness. So choline citrate along with magnesium, 220 milligrams twice a day. That gives you 440 milligrams at a minimum of elemental magnesium with the uptake enhanced by the choline citrate. Then you correct choline deficiencies. Choline becomes acetylcholine, a beneficial neurohormone. Choline becomes cholinergic bile salts that stimulate the liver to get rid of fat-soluble toxins. And citrate is the Krebs salt that energizes the mitochondria and alkalinizes rather than acidifies the body. If you have enough magnesium, you push the protons out of the cell into the urine, into the sweat, into the stool, and you get rid of them. But you must enhance the uptake today with choline citrate in order to get the magnesium into the cell, into the body, into the brain, into all of metabolism. One of my favorite people writes about metabolic acidosis for New England Journal of Medicine and Harrison's Textbook of Medicine. This is Julian Seifter, the son of Sam Seifter, who was one of the authors of that classic 1986 article. And Julian at Mass General has been teaching about how important metabolic acidosis risk is, which means magnesium and potassium deficiency. Potassium backstops magnesium, but magnesium is absolutely essential. Magnesium activates ATP. Magnesium activates many enzymes that potassium does not. So it's helpful to have some potassium from the diet, but you must have magnesium, and it's easiest to take this as a supplement. So, what about cell acids and minerals? There are many minerals that are essential, both macro and micro. For example, we have a relative excess of calcium. We have many calcium channel blockers that are medications available today for blood pressure reduction. Yet, if we want to know about the minerals, we need to know about the provocation, the removal of minerals from the cells and deposit into the urine. Protein renewal, protein production, protein efficiency in healthy people is more than 90%, and wounds heal quickly. People with metabolic acidosis may have a protein efficiency, a protein production of less than 10%. Magnesium is often considered the forgotten electrolyte. One of my mentors, Mildred Seelig, spent a lifetime trying to get people to remember the importance of magnesium to balance out calcium and to do the hundreds of beneficial things that magnesium rather distinctively does. We have a review article in the Watson and Preedy textbook for you to take a look at and consider. Here's the classic Seagard-Anderson nomogram. The N stands for normal. That's pH balanced and carbon dioxide bicarbonate balanced. And you notice the up and to the left, that large bronze look, that's metabolic acidosis. There are many conditions where metabolism is altered by either breath and respiration or by renal function. But it's important to remember that the normal range for CO2 and pH is very narrow. It's exquisitely controlled. Normal plasma pH is controlled within a few thousandths of a pH unit. Metabolic acidosis means deficiency of divalent cations, mostly magnesium, needed to restore balance. A lot of this is about balance. It's kind of the Goldilocks scenario. Not too little, not too much, just right is just right. And now, with the benefit of technology, we know by self-tests how much of what is needed, how much antioxidant, how much magnesium, how much microminerals are needed. To make this assessment, we find it easy to use a little test kit which comes with hydrion pH color reactive material between 5.5 and 8 is the ideal physiologic range, and the colors allow you to tell whether it's sandy color, which would be too acid, whether it's green color, which would be just right, or whether it's blue color, which would mean catabolic illness. You measure after 6 or more hours of rest. The urine fluid equilibrates with the gastrourinary tract lining cells, and one time a day after rest, that urine pH predicts how much magnesium and choline citrate you need through the day. During the day, there are many factors, at least 20, that influence urinary pH. Some colleagues want to know about saliva. Most people do not have pure saliva in their mouth. They have serosanguinous fluid that is produced by the inflamed tissue in the mouth. And so saliva, unless you use a Kirby cup, pure saliva cannot be captured except by a Kirby cup, which means putting a little piece of plastic over the parotid gland and slowly collecting pure parotid saliva. That can be used, but it's a bit more cumbersome than just peeing on the strip and looking at the color. So I'm going to reinforce what I've been saying. If you're too acidic, that's wrong. That's harmful. That's metabolic acidosis, which means a pH after rest of less than 6.5. Green is healthy, 6.5 to 7.5. Too alkaline is catabolic illness, where you're cannibalizing muscle protein because of impaired metabolism. You're slowly tearing yourself down and cannibalizing yourself if you have catabolic illness. Here is a table that we developed probably 25 plus years ago that makes it simple to purchase whole foods. You want 80% of what you eat when you're recovering from a wound to be more alkaline. That would be on the right, and only 20% or less on the left, the acid forming. This simplifies going to the market, buying whole foods, avoiding plastic and contaminated, preservative-rich foods, processed foods, by shifting more and more to a whole foods, alkaline-forming diet. The Joy in Living the Alkaline Way is a book that we make available to download for free, a digital copy. Shows you how to alkalinize foods and water, healthy water, how to be active, and how to check your first morning urine pH, how to judge how much magnesium with choline citrate doses you need during the day, 2, 3, 4, maybe 5. We encourage abdominal breathing, which reduces stress. We recommend a green light and being outside in sunlight for 20 minutes twice a day. Eat in harmony with your nature and lifestyle. Eat locally grown, vine-ripened, organic, or biodynamically derived as possible. Make restorative sleep a priority. We recommend half an hour to transition from the doing of the day to the being of the night. We recommend a half an hour transition from active to rest. And with this half an hour transition, we achieve restorative sleep in 90% of people who have previously been unable to sleep deeply and well because there are so many benefits, including to wound healing, from restorative sleep. We want to work all of our muscles and relax in some proportion. Relaxation response, mindfulness, meditation are important health-promoting activities today. Nature, nurture, and wholeness guide our choices. Alkalizing food and water, activity, as I've indicated, to balance out and keep you moving. Magnesium with choline citrate to triple the uptake of magnesium and correct the choline citrate deficits. Abdominal breathing, just breathing deeply into the abdomen causes a massage for all the organs and de-stresses. It reduces the stress hormones of cortisol and adrenaline. Green light and sunlight also harmonize hormones, neurochemicals, immune defense and repair, so that we can eat in harmony with our nature and our lifestyle, mostly locally grown. In our front yard, we have no lawn to mow. We have a 15-year-old permaculture biodynamic food forest from which we harvest herbs and whatever is seasonally ripe on an almost daily basis. And make restorative sleep a priority. And walk. Ideally 8,000 to 10,000 steps a day. Walking turns out to be an excellent exercise. And if you amble and ramble as well as walk a distance, you're likely to meet nature, nurture, and wholeness. And be delighted with the wound healing restorative properties as summarized here. These have been just a few slides. I would be happy to take any questions that you may have about how to do a depenicillamine provocation to check for essential minerals and toxic minerals, how to do a C-cleanse correctly so that you can calibrate the amount of antioxidant ascorbate needed so that you can on a daily basis remove the toxic minerals, correct for metabolic acidosis, and live in harmony with nature, nurture, and wholeness. Now, okay. Any questions? Because I have a few more minutes, and I'd be delighted to address anything that I can to enhance your understanding of the physiology of wound healing. It is today essential to get good clinical results, to have working with you nature, nurture, and wholeness. Ascorbate based on the C-cleanse, magnesium and choline citrate based on the urine pH. Depenicillamine, I am urging you to become familiar with our protocol on depenicillamine. This measures all the essential minerals as well as the toxic minerals in a single 24-hour urine. Depenicillamine is the only chelator that goes through the cells and puts into the urine, sweat, and stool the minerals, cellular minerals. And I have been using the depenicillamine protocol for decades with great success, correcting whatever essential mineral is lacking, often zinc or molybdenum or vanadium or chromium, and getting rid of the toxic metals, especially lead, mercury, nickel, cadmium, and arsenic. So,
thank you so much, Dr. Rafael, for your contribution and for contribution book thank you so much. Thank you.
Thank you very much. Shall we have a coffee break? I think based on our program, now we are having a coffee break. Is it, Prof. Marian? We are having coffee break now, right? For up to
Not have a coffee break. Continue, please.
shall we continue?
Yes, Dr. Koval.
Oh, all right. Sorry, man. Yeah, okay. Yeah, sorry. Then Dr. Svetlana, is she here?
Yeah. Good.
Yeah.
Good morning or good evening.
Good morning.
Different
Hi.
time zones.
Yeah, hi.
Hello. I am. So you can see my screen. Not yet.
Not
I
yet.
share my screen with the arrow, right?
Yes, correct.
Okay. So let me just. Okay.
Yeah, let me introduce Professor Dr. Svetlana Kaval from the United States, and the topic for today's presentation is direct printed aligners in conjunction with mid-facial skeletal development procedures.
Yes. Can you?
Thank you, Doctor, so much for your contribution and for your presentation as well.
Thank you. I'm trying to find the screen. It should be in here.
Do you require assistance?
Yeah, now we do it. The entire screen should be. Can you?
Do you need help?
Yes, I need help.
Okay, let's see. So after you press the Present Now button, a pop-up will show up on your screen. And to the top, the right corner is the option for the entire screen.
Let me see. It does have the. Oh.
The Present Now button is the arrow going up. That's to the right of the smiley face in the middle.
Okay, are you able to see my screen?
Yes, but
yeah, but you shared the meeting, the Google Meet presentation. Yeah. You need to now open up the PowerPoint presentation.
It is open. It is open. I'm sliding my screen. It's the Mac.
In that case, press again to share the screen.
It says stop sharing.
Yes.
Okay, and now.
So press the button to share the screen. Do you see the pop-up window?
Yeah, there's a pop-up window, but the only window it's showing it's the actual our meeting screen.
Yes, you have the three options. The first one tab, the second one is window, and the third one is entire screen. Press on that.
Okay.
Now, do you have an option called entire screen?
Yes.
Select that. Yes, select that and press share to confirm.
Oh my God. Mm-hmm. Is it showing?
Not yet. No, it is not.
Okay. Is it showing right now?
Not yet.
No. Did the pop-up disappear?
It's showing me. It's asking for Google Chrome to be able to
yes,
record.
Please accept.
Let me see. Let me see if I can do.
Oh.
Dr. Koval, you are muted. Can you open your microphone?
It's asking me to quit and to restart, which I already did.
You shouldn't be asking that.
No, no, yeah, it's normal. She must not be running on Windows.
Okay.
Is anything happening right now?
Yes, we can see it. You can switch to the okay, now we can see it.
Perfect. Perfect. Okay. Yeah, some technical things. So I'm glad we resolved everything, and I'm very honored to present today with the topic of the midfacial skeletal expansion and the use of 3D printed aligners. And I do not have any monetary benefits or any reimbursements from the companies or the software I'm using. A little bit about myself. I'm the owner of the airway-oriented practice, the airway specialty practice in orthodontic practice in Boca Raton. The book on T-scan digital occlusal analysis in orthodontics was just, with the chapter on it, was just published in 2024. It's already available, and the chapter that was edited by me is a part of this book right now. We're also working on the non-surgical maxillary skeletal expansion protocols chapter for the Elsevier with Professor Murnescu, and the US and Canada patent was filed for the guided midfacial skeletal expansion protocols in conjunction with the midfacial skeletal expansion. So the topic I'm focusing on today is the use of the midfacial skeletal expansion, which is the procedure that is pretty recent relative to the traditional orthodontic approach in expansion. And what I will be talking in particular today is the use of the midfacial skeletal expansion with so-called bone and tooth-borne skeletal expanders. And in our practice, where we do 90% of the adult cases, not only adult cases, so 90% of the patients who come to our practice, because we are airway oriented, we put a lot of effort into researching and clinical observations of the effects of skeletal expansion in growing individuals and in adults. And the protocol I'll be describing today is used in adults, in non-growing individuals, which produces skeletal expansion. So the 5 main outcomes of the skeletal expansion in our experience are not limited to, but can be described as the maxillary width increase, the increase in nasal airway volume, which is an inevitable effect of the midfacial skeletal expansion protocol. It's the forward midfacial translation. It's more of an innovative outcome that is very limitedly described in the literature, and the septum spatial improvement, because the position of the septum is directly related to the increase in the nasal airway volume, and it is directly related to the position of the maxillary halves, and the facial lift effect, which is the skin effect, the effect on the facial tissues. So I'll be starting with the facial effects from the effects on the facial tissues, which are related to the bony, underlying bony tissue changes. So with the midfacial skeletal expansion and with the midfacial protrusion, what happens is we are observing significant changes in midfacial protrusion and in forward midfacial positioning, which results in most cases into correction of class 3 to class 1, and even in class 2. So the inevitable effect of the midfacial skeletal expansion, which is the maxillary skeletal expansion, is the change, is the movement of the whole midface forward, downward, and outward, which causes more fullness to the midface, which causes the whole maxillary complex detachment from the surrounding perimaxillary bones and sutures, and improvement of the facial skin profile. Another effect is the nasal septum position, and which is in particular interest is the protocol that we just recently developed with the use of the piezocortical guide. So the piezocorticotomy is an adjunctive procedure which is used to facilitate the symmetry of the maxillary skeletal expansion. And what it does, it is produced in conjunction with the placement of the maxillary skeletal expander itself, the appliance itself, and it's the piezocortical incisions along the mid-palatal suture. The way we modify this procedure is we are using a specific guide, which is individually custom planned and custom fabricated guide, which produces the specifically planned notches for the piezocortical incisions. And these notches are planned in relation to the position of the septum and the mid-palatal suture itself. So the point of introduction of this part of the procedure is to ensure that the nasal septum remains in the middle and it's not dragged to either side with the expansion and with the movement of the midfacial complex. One of the recent studies is showing a study by Dr. Liu was showing that even with the MMA surgeries, around 6.5% of all patients that underwent MMA surgeries, they still required any type of rhinoplasty, septoplasty, any type of nasal airway revision to improve their nasal breathing or for some other anatomical procedures. So this procedure in particular, the introduction of this piezocortical guide, which we have patent for in the US and in Canada, that improves the outcomes in terms of the symmetry of the nasal septum position. This is the outline and the pictures, the graphics of the incision that is made before the positioning of the midfacial palatal expander, and this is the location. This is the location of the suture. It's the suture and the incision itself along the palatal suture. And as you can appreciate, the numbers, in particular, the number 7, the figure 7 here in the picture, it points at the separation of the mid-palatal suture.
The main concern and the reason why I met Dr. Koval was because I saw her lectures on YouTube in regards to the issues that people have in terms of breathing. And all my life, I wasn't able to sleep. I would wake up at 3 a.m. or 4 a.m. in the morning, or I would only have 4 hours of rest. So that's why I came to Dr. Koval to be able to see if he was able to help me in regards to that. So what Dr. Koval recommended me to do was to do an expanded Markby procedure, which I expanded up to 10 millimeters. And so throughout the entire time, I was expanding once or twice a day. So Dr. Koval recommended I do a procedure known as Markby, an expanded Markby procedure, which she expanded up to 7.5 millimeters of bone expansion and then 2.5 millimeters of molar tips. And by doing so, it greatly expanded over here horizontally. And over months, that she recommended me to be able to do 1 key turn a day. Well, now I'm actually feeling way better than before. I can actually go to be able to sleep. It only takes me like less than 10 minutes to be able to go to sleep at night. I'm reaching deeper levels of sleeping. I'm having my full 8 hours. Also, I'm breathing much better. I don't have any more congestion at all. So I definitely recommend that anyone who has a breathing problem to go check out the idea of that.
So that was just the patient experience with the procedure itself. The main impact of the Markby expander and the Markby expansion is to improve nasal breathing, as was shown in multiple Stanford studies. Now I'm moving on to the third effect of the midfacial skeletal expansion, and as observed in our clinical experience with more than 300 cases, adult cases with MARPI expanders in particular, not the MSC cases. And as you know, MSC is the brand name for the appliance that was introduced by Dr. Von Moon, while MARPI is more of an umbrella term, which is more of an individual custom design and can incorporate different types of designs. So one of the major effects that I would like to emphasize is the forward midfacial translation of the midfacial complex. And what happens is that multiple studies, not only our clinical observations with the CBCT studies, they are showing that the perimaxillary sutures, they are separating around the maxillary complex, and that causes the so-called squeezing forward and outward effect with the downward component. So there is also a relationship between the amount of expansion, and we are always, I want to emphasize that we're always talking about the separation, the bony separation of the two maxillary halves compared to increase in intermolar width. So here, it's the amount of the bony separation between the two maxillary halves that determines the amount of forward midfacial translation. In our observation, any amounts of more than 7 millimeters, 7.5 up to 8 millimeters, and more, they cause some degree of forward midfacial translation. We've done cases where the patients were expanded up to 11 and 12 millimeters of pure bone separation, and as you see on the screen here, the midfacial, the pteromaxillary suture is also being separated. So pterygomaxillary suture is one of the most difficult sutures to separate, as it attaches it's the point of attachment between the base of skull and the facial skeleton. The effect, again, the degree of skeletal expansion, and I'm referring to pentagons, as I can schematically draw the skull itself in purple color, and in light blue, baby blue color, it's the midfacial complex. So the more expansion is produced by the midfacial palatal expansion procedure, the more there is a squeezing forward and outward effect of the midfacial complex and the forward movement itself. There was just a recently published study by Dr. Kim, and it's showing that the effects of bone-borne maxillary expanders, they do cause perimaxillary sutures to separate. And the most important part is that they have designed the study to compare the ATOS expanders, their proprietary expander, with the C-type expander. And what they showed that the degree of different suture separation was different, but there is. So these slides just show the position of the main sutures, and what they were showing is that frontozygomatic sutures, zygomatic and maxillary sutures, they were decreasing in their width, while the frontonasal, frontomaxillary, maxillary, nasomaxillary, internasal, intermaxillary sutures, so the sutures within and connecting the maxilla and kind of allowing for that separation, they were increased in higher degree, in higher amounts, compared to the zygomatic maxillary sutures and the front. So the sutures that are squeezed during that forward movement of the face. This is another slide from the same study showing that there is a distinctive separation in the sutures, and it is not referred to as a fracture. It's not a fracture. So the fracture, by definition, is the bone damage. It's the breakage of bone in the locations that are not supposed to be natural sutures. The suture separation is the act that happens in the sites of natural bony junctions, which are the sutures that naturally happen in the human's body. So once we observe those suture separations, they're not to be considered the side effects of the maxillary skeletal expansion or midfacial skeletal expansion. Multiple studies, one by one, are showing that these separations are the inevitable effect and are related to the degree of expansion and are related to the design of the appliance that produces this midfacial separation. One of the important effects is the increase in nasal airway volume, which was also shown in multiple studies. And what I want to draw your attention to is that one of the most commonly used measures of the expansion is the measurement and the increase in intermolar width. While the intermolar width is not an accurate determinant of the actual success of the expansion, the intermolar width is the reflection of the molar tipping more than to a bigger extent than the bone separation. So there should be a more accurate component to measuring the expansion. And one of the components that has been recently used was the measuring of separation between the two halves of the maxillary bones, but also what contributes to the effects of breathing and airway resistance is the component that we've been measuring in our practice, and this is the distance between the medial pterygoid plates of the sphenoid bone. So that effect is the most important because that effect relates to the position of the PNS. It relates to the attachments of two major muscles of the pharynx. So among the 6 major muscles of the pharynx, the salpingopharyngeal muscle and palatopharyngeal muscles are the 2 muscles that are directly attached to the posterior PNS, to the posterior nasal spine and that area. And the position of the medial pterygoid plates is something that has a direct effect on the lateral, on the width of between the lateral walls of the pharynx, and as a result, the improved resistance of the airway. So here we see cases before and after, and we see that in some cases, this distance improves significantly from, for example, case 5, from 28 millimeters to 33 millimeters by almost 6 millimeters. Case 6, before and after, 28 millimeters to 32 millimeters, almost 5 millimeters here. In some cases, there are lesser effect, which also depends on the amount of separation, the amount of the intermaxillary separation, and also depends on the design of the appliance and if the posterior nasal spine was actually separated. So in our practice, it's important to design appliances in such a way that the mid-palatal suture is separated all the way from the ANS to the PNS, avoiding any kind of the V-shaped expansion, ending up with a nice parallel expansion at every point. So this is just a growing individual in 13, 14 years old. She started with a crossbite, anterior crossbite, and bilateral posterior crossbite as well. So we expanded her 13 millimeters in the front, almost 10 millimeters closer to the middle third of the palate and closer to the PNS. So this is the drastic improvement in her airway volume, starting with the nasopharyngeal airway volume and the oropharyngeal airway volume just from the maxillary midfacial skeletal expansion procedure. So that allows us to conclude, and it's just the preliminary findings, that the midfacial skeletal expander, the expansion procedure itself, that causes, without any type of intervention on the mandible yet, that causes the improvement in the patency and the decrease in the resistance, the airway, upper airway resistance. One of the studies conducted in 2012 had 1,200 patients that were divided into age groups. And as we're constantly using the CBCT as an indirect measurement for the airway volume, and it's been constantly referred to, while it's not a golden standard for the airway, for the sleep apnea diagnosis or any type of measurements. But there were studies, and this is one of the studies that is showing the numbers, and the numbers are the total volume, total airway volume, and the minimum cross-section area volume. So each age is characterized by the average norms for the total airway volume and the minimum cross-section area. And it was shown that the airway dimension, the length, it increases from 6 to 12 to 20 years old. And that the total airway volume, it correlates with the smallest cross section, not with the length of the airway volume. It is important to note that the most critical is the choke, so-called choke area, which is the minimum cross-section area. And this area also increases while the patients grow, and that reaches its more or less defined dimension at the age of 14. So here, the same study, they concluded there is a reflection, or there is an association between the risk of severe, moderate, and mild obstructive sleep apnea with the minimum cross-section, with the minimum dimension of that so-called choke area, and the risk of severe obstructive sleep apnea has correlated with the minimum cross-section of 52 square millimeters and less, while moderate was related to 52 to 110 square millimeters, and mild OSA with 110 and more. There's also a relationship between the airway architecture and shape in different skeletal classes and different angle classifications. And we see that the skeletal class 3 has a more as a straighter profile, while skeletal class 2 has a more of a curved profile with more of a protruding due to the forward head posture. The angle classification, as you see, so we see a bigger airway volume in class 2 within the nasopharyngeal airway space, while there is less in the nasopharyngeal airway space in class 3s, and a little bit more in the oropharyngeal airway space. One of the major effects of maxillary width increase is of the midfacial expansion is, of course, the maxillary width increase. And what it says that that obstructive sleep apnea, and it was shown, is so that is one of the options of treatment of obstructive sleep apnea in adults as compared to DOME. The destructive osteogenesis maxillary expansion. So this is an alternative along with the DOME, as was shown by Christian Guilleminot and Audrey Yoon and Stanley Liu. It's a viable option for treatment of patients with obstructive sleep apnea. Now I would like to refer to some growth changes in the maxillary base, and why that matters is because while observing and while looking through scanning our CBCT scans, and we have to refer to specific norms. So these norms were taken from the studies by Ramnanda and from the atlas of the frontal cephalograms, and it shows that the maxillary width, in particular from MX to MX points on the anterior posterior cephalograms, it grows from 56 to 70 millimeters in females and from 58 to 76 millimeters in males. So if we're talking about a grown individual, we are looking at 72 millimeters of the maxillary base width in females and approximately 72 to 76 millimeters of maxillary base width in male patients. This is just the graphic representation of how the maxillary base width increases with age from 5 years old to 18 years old. And this is the changes in the maxillary base from midline to the point MX. So we're looking at the increase from 27 to 36 in females and males. We're also looking at the interzygomatic points. So when we do maxillary expansion, there is a broad discussion on how the interzygomatic width changes with the midfacial expansion. The ideal proportions for the grown individual is 135 millimeters in males and 126 millimeters in females. Same thing if we are measuring the same width, the same dimensions from the midline to the one of the points. It grows from 53 to 64 in females and from 54 to 66 in male patients, and it reaches its final finite dimension at the age of approximately 18 years old. This is one of the most important. This is the nasal width measured from the most lateral point of the nasal aperture to the most lateral point of the nasal aperture on the other side, and we're looking at 32 millimeters of nasal width. In ideal world, the nasal width has to be the same as the nasal base.